And Sean, you there?
Hello.
Hey, Sean.
Hey, how's it going?
Good. How you doing?
Good, good. If you wanted to test your presentation, you totally can.
Yeah.
Hello.
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 Hey, how's it going?
It says send request for sharing.
Okay, you should be able to share now.
All right. All right. Can you see that?
Yep. Yeah, that looks great.
All right.
Just made me go to full screen though.
What's that?
Just go to full screen though when you show your slides.
Yeah, it should have been on full screen. I had it on full screen anyway. Is that full screen now?
I don't know, not on mine. What about for you, Sean?
It looks full screen on my end. Um,
Yeah, maybe I need to go to full screen.
I got you. Yeah, I chose full screen as the choice, but
Gotcha. Hey, Robin.
Hey, how are you?
hey, Robin.
What's up, Lyle?
Thanks for doing this, Lyle and Robin.
Sure.
Thanks for having me. Are we interacting again? I forgot, Kevin. I did this a couple of years ago and I forgot. Did we interact or do we just
Yeah. So
present?
I've got a short intro, then Lyle's going to go. I've got a few questions for Lyle at the end of that. We'll see if there's any questions, but he's on a time thing, time limit. And then I'll throw it to you. You'll share. We'll do a couple questions, and then you can either bug out. I mean, this thing's 2 hours, so
Okay.
once you get done, I mean, I'm going to be going for another hour probably. So
Okay. All right, great.
yeah,
I can stay and learn.
yeah, right.
Exactly.
Yeah. I think you know all this stuff,
No, I can always learn.
yeah, it's a little bit of an endurance test. Nice 2 hours.
I love it. Should I check and make sure I can share or does that
Yeah.
matter?
yeah, you can test it.
Okay, just give me 1 second. Let me just see here. Make sure I'm enjoying that. Okay. Let's do a quick little share here. Um, allow. And let's just see. Can you guys see this?
Yep.
Yes.
So if I open it, let me just check and make sure that you can see the PowerPoint. Okay,
Yeah, that looks great.
perfect.
Perfect.
Close it up. Stop share if I can find that.
We'll start right at 6. Lau, what's your hard stop?
It's not a hard stop. I got a board meeting at 6:30. I got to sign in on, but I'm not. I can kind of be passive while it's going on, so
Okay.
I can sign in while we're still talking if I need to.
Okay. Well, I just want to make sure we don't screw you up on your.
No, I'm good.
Can the audience ask questions, Kevin, or is it's truly a webinar? It's recorded, or people?
Yeah, it's recorded. Yeah, we will ask them to put questions in the Q&A.
Gotcha.
So yeah, we encourage that. It's just a question of managing it all, that type of thing.
Okay.
Did you get any snow in Washington?
No snow. Have you
No,
guys gotten
really?
no? Have you gotten snow down there?
No, it's cold though. It's
Yeah,
20 degrees
cool.
this morning.
Yeah, it's really cold. My daughter's at FSU, and she just called me and she's like, it's freezing.
Mm. Yeah, freezing is relative.
Yeah, that is true.
Yeah, I was in Cleveland over the weekend. Now's not the time to fly anywhere, I'll tell you.
No
Yeah,
kidding.
did you get stuck?
Oh God, yeah.
So painful.
Yeah. Yeah. And then snow was coming too. It was going to snow that night in Cleveland. I was like, I gotta get the heck out of here, man.
Yeah, get me out. I remember many, many snowy days in Pittsburgh on the Steelers sideline.
Oh,
Being so cold.
yeah, I bet.
You don't get stuck in the cold too much, Lyle.
Try not to. Yeah, we don't play very cold areas. We've had occasion where we played Arkansas or somebody late in the season. It's been rainy and snowy and nasty, but if I had to do it every weekend, I might find another job.
Yeah,
It's no fun.
right. Yeah, it's not fun. It gets harder as I get older too.
No kidding. I
Mhm.
was watching the Packers Eagles game last night, and it wasn't snowing, but you could tell it was starting to get cold up there, and I started feeling bad for Mike Ryan. Have to be in there
Yeah,
in Green Bay for those games. It's
that's
terrible.
right. That's right.
Robin, I've enjoyed like seeing Alex Smith on the NFL telecast.
Yeah, yeah. He's doing a good job. It's interesting to watch him. He's mature. I mean, he's gotten so much better.
Oh yeah, yeah, I think so too.
It's
Hey,
more of
Kevin, you'll appreciate this. Kevin dealt with him back when we fixed his AC joint.
yeah.
So I saw him at Robin's course a few years ago. He was still rehabbing from his tibia, and he still had his X Fix on. He was downstairs, and we went down and said hi. Freddie Foo and I were there, and I said, "Hey, Alex, it's been a long time. I met you when we did your AC joint with Dr. Andrews." And he said, "Oh yeah, the old fiber wire through the coracoid trick. I remember that."
Wow.
It's like
He
great that
remembered
that's go ahead.
20 years later. He remembered the fiber wire cutting through his coracoid.
He remembers it like that. It
Oh
was
yeah.
yeah. I remember the first time I met him, it's the first thing he told me.
Yeah, because Dr. Andrews didn't like using a graft, so he would just take a piece of, back then he'd just take suture generally, like PDS,
Yeah.
but I think they just come out with fiber wire, so he decided, let's try this new super suture.
Yeah.
And so he wrapped it around his clavicle and around his coracoid, and of course the next year it saw through his coracoid. And he ended up having to come back. We just took his coracoid tip off, didn't even repair his muscle. He did
I know
fine.
it's so interesting, and he played. It's so
Yeah,
crazy.
yeah. I mean, he basically had his conjoint tendon zinged, released.
Yeah, it's so interesting, and
Yeah,
he has no deformity. He looks normal.
yeah, it's crazy.
Yeah, but it was the first thing he showed me. I remember I was at his physical. He's like, check this out.
I didn't think there was any way he'd remember when I said hi to him. But
It's really funny. And little did I know I would be scrubbed in, 20 more times on his
no kidding.
surgeries. It's crazy. Are you looking forward to the ski meeting, Kevin?
Looking forward to what? I'm sorry.
The ski meeting. You're going again, right? To the
Oh,
ski
in
Park
Utah?
City. In Park City, yeah.
Yeah. Yeah, I think so. Yeah. I mean, it's backs up to our baseball course, so it's always a little bit
I
of
know. I'm speaking of the baseball course like the week before, right?
it's the same. I mean, it's like the weekend and then,
Oh, no, I'm speaking of a different baseball course then.
okay. Yeah,
Yeah,
we got one down here.
gotcha. Okay, this
That's
is
the
like an
same.
MLB course in Phoenix.
Oh, yeah, that's like the week before or something,
Yeah,
right? Yeah, I'm not going to that one.
okay.
No, I'm starting to cut back more. I mean, especially after Cleveland, man. I'm
Cut back, man. You're going every weekend. What do you mean cut back?
yeah, well, it's not going to be anymore. I'll tell you that. I
We'll check in 6 months.
yeah, you'll see. I Had a couple Saturdays at home. I'm like, man, Saturdays are nice.
Like it's kind of nice.
Yeah, it's kind of weird. You can do something,
Yeah.
not sit at Atlanta airport.
Right.
Stupid.
Thanks for helping with Marley too, Kevin. She is extremely appreciative. Like
Yeah, sure. She's a great
you
kid.
walk on water, and I do too. But she's like, I think you energized her. Like you helped her tremendously.
Oh,
Not just
good. Yeah,
physically,
like I
but
say, she's a
mentally too.
good kid. I mean,
She's been through the
she just
ringer.
can't get ahead of herself, though. She's trying so hard.
Yeah.
All right, I say we rock and roll. Sean, you ready, Brett?
Yeah, we're good to go.
Okay. We'll get started in 1 minute. Hello, everyone, and thanks for joining this masterclass webinar. I'm Kevin Wilk. I'll be co-hosting this. Tonight's topic is ACL injuries, surgery, and rehabilitation, how to improve outcomes. And we've got a fantastic group of individuals that'll be presenting this evening and sharing their insights. Masterclass is a series of deep dives into particular topics. And certainly this time of year is kind of an ACL time of year with football and other sports starting to ramp up, such as basketball, but certainly with ACLs. I'd like to thank Northeast Seminars for putting this particular webinar on. They're our host and webmaster. Sean and Brett are running the show, so to speak, behind the scenes. So thanks so much for that. When I think about ACLs, and I wake up in the morning, I love ACLs. This guy actually tore his ACL, a freestyle skier out of Switzerland. And a little bit of a daredevil, to say the least. He made that jump and he made it well, which was thankful. So let me introduce our faculty. So first we have Robin West. Dr. West is from Washington, D.C. She's the president of INOVA, Musculoskeletal Services, and chairman of sports medicine. She's also the primary team physician for the Washington Nationals baseball team and other appointments at Georgetown and so forth. So Dr. West, thanks so much for joining us.
Yeah. Thanks for having me.
And then next we have Dr. Lyle Cain, co-founder of Andrews Sports Medicine in Birmingham, Alabama. He's also a team physician for the University of Alabama, also numerous joint appointments as well. Dr. Cain and Dr. West are certainly proficient in the area of ACLs, and we're really, really fortunate to have them this evening. They'll be doing a PowerPoint. We'll have some questions at the end of each presentation. So feel free to ask questions. Use the Q&A. Do not use the chat box. And I'm going to stop my share, Lyle, and you can go ahead and punch yours in.
All right. Thanks, Kevin. I appreciate you having me tonight. Does that come across okay?
Absolutely.
Good. So I'm going to talk about ACL and meniscus surgery in 2025, talk about my technique and some rationale. And we're going to talk a little bit about biomechanics, not just basic ACL stuff, because I think that's some of the changing technique over the last 10 years has really affected the biomechanics and probably affects you as physical therapists and how you deal with these patients. So we'll talk about that. So for disclosures, I am a consultant and do have a relationship with Arthrex. I get research money from several different companies through ASMI, our research nonprofit. This is my 25th year with the Crimson Tide. Grew up as an Alabama fan, so it's been fun to work with the team over the last 25 years. This was 2020, our last national championship, and a lot of this, Devontae Smith catching touchdown passes. This was the SEC championship game against Florida. If you guys watched the game last night, he's still doing it for Philadelphia with Jalen throwing the ball to him. So a lot of fun to see them succeed and see what, as they progress through their career. So that year we won the national championship, beat Ohio State by 28 points in the championship game. Great team. And one of the stars of that team was Landon Dickerson, who again played last night. Interestingly, Landon played 20 days after an ACL, so he really messes up your return to play criteria because he's number 69 right there, snapping the ball the last three times at the end of the game. And he literally had surgery 20 days prior, ACL reconstruction, medial meniscus repair. And then he picked up Coach Saban and carried him across the field. And really, my heart sank because there was a player laying on the ground. You can see on the left corner of the screen, the state trooper looking down. It's because there's two players laying on the ground that Landon had to step over carrying Coach Saban. And I thought he'd end up re-tearing his graft and breaking Coach Saban's hip. So pretty scary moment, but Landon had a great, it was really important for him psychologically to get in the game after he transferred to Alabama. And so glad to see him playing again last night for the Eagles and having a good career. Well, the next year we played Georgia in the national championship game and felt good about it going in. We're tied up in the second quarter, 3-3, and Bryce Young throws a pass to Jamison Williams. Jamison's wide open despite four DBs being in the area, and he has probably the most aggressive pivot shift you'll ever see on video. He plants in valgus, a little bit of flexion. His tibia subluxes and pops back into place. You'll see it in slow motion. Probably the best ACL pivot shift you'll ever see live. So you can see it reduce immediately. The interesting thing about that is that Jamison thought he was fine. He was helped off the field and he was convinced he could play, but he looked so bad hitting the ground we didn't let him play. And thankfully, of course, had an ACL and ended up having reconstruction prior to being drafted by the Lions. So I'm going to talk about the pertinent anatomy of the ACL and anterolateral knee. I'll talk a little bit about the biomechanics of the ACL and how that affects how we treat these injuries. Then I'm going to talk about my rationale and treatment algorithm for ACL and meniscal repair in current times because I think there's some controversy. It may seem like ACLs are pretty standard, but there's a lot going on in the world of ACLs that I think will affect all of us. So basic anatomy, this is, tibiofemoral joint obviously has the two menisci, medial lateral meniscus, the cruciate ligaments, the ACL and PCL control rotation and posterior translation primarily, and then your collateral ligaments. If you look at it from this angle, the cruciate ligaments, obviously, the ACL goes from the lateral femur to the anteromedial tibia, from the lateral femoral condyle, part of the intercondyle notch, and it actually has a large footprint, and we'll talk about that. And we really, I think one thing we have to realize in orthopedics is we're not reconstructing anatomic ligaments. In most of these cases, if we don't repair the ligament, we're actually making a temporary strut, not a true ACL. And I think we forget that sometimes when we talk about these surgeries. It's also to remember that some of the more severe injuries don't necessarily have big swollen effusion knees, and they're not always painful when they first happen because the swelling hasn't occurred. If you have a capsular injury such as a collateral ligament injury, bad MCL, bad LCL, the blood comes out of the knee and actually goes down the leg, and they won't have a big effusion, so don't be fooled by that. Some basic tests for ACL, obviously the Lockman exam is kind of the gold standard. Anterior translation. This has a lot of, I think, inter and intra-observer variability. I've been teaching fellows now for 25 years, and I can tell you the incidence of a fellow getting a correct Lockman exam is not near 100% on a patient. And so I think a lot of it comes down to your kind of history in your mind of how they feel and feeling side to side each knee. The pivot shift is the same way. Also can be really tough to do sometimes, especially in the awake patient. Dr. Andrews has this modified pivot shift that I learned to do. You can do it on a awake patient or in the injury tent on a football game, and it doesn't require quite as much displacement. You can kind of feel the fibular head rotate and pop back into place as you flex and rotate the knee. So this is something I learned how to do, and it's really helped me more than Lockman has. And the anterior drawer is kind of the old standard. You see the trainers do this on the field all the time, but it's not that often the anterior drawer is grossly positive. I don't think I use that as much as other testing. So basic MRI, obviously normal ACL on the left, going from the femur down to the tibia. On the right, there's no normal ACL there. So this is a disrupted ACL, pretty obvious. Initial treatment, we will sometimes aspirate blood from the knee just for pain control and swelling control. I think it's important to get these players into physical therapy and treatment early. A lot of times we'll see community athletes that get hurt, and the first thing they do is get put in a knee immobilizer for 2 weeks before they see us. And a stiff knee coming into clinic for an ACL surgery is not a good option. So we always try to send them to physical therapy, do some modalities, early range of motion. I always have to tell athletes that really with an ACL tear, you're not likely to hurt anything by walking around and moving it and bending it and using your quad. You really don't want to just sit there static. Surgical treatment is indicated in most young active people. I think the controversy comes down to timing of surgery, the best graft source, which we'll talk about, graft placement, which we'll talk a lot about, and then other procedures. Robin's going to talk about ALL, LET, and osteotomies, and then return to play criteria. I know Kevin will talk about as well. So as far as autograft options are concerned, the three kind of go-to options, patella tendon autograft is probably the gold standard still, even in 2025. Hamstring tendon has been used a lot by certain surgeons, and in our hands we use it in kind of the middle-aged and older patients. And then quadricep tendon, either with or without a bone plug, has become really popular in the last 5 years, and is a good graft, but also has its own concerns. In terms of graft options, they kind of look like this when you look at the lower right picture. So you prepare the patella tendon with bone on each end. The quad tendon you prepare with sutures on each end, and then the hamstrings usually fold into a four-stranded graft to make a thicker kind of tubular rope type structure. You can always use allograft. Allograft was really popular when I came into practice 25 years ago, but I think most of us have realized that allograft has a high failure rate, and so it's really reserved for lower demand patients, and for people that really are not going to put a lot of stress on the knee, probably because of some concerns of vascularization and problems that cause re-tear. So a lot of different options for allograft, but really have not been as popular in the last 5 years, I would say. So this is kind of a busy slide. I included a PDF that Kevin can send. It just talks about the advantages and disadvantages of each graft, and we're not going to go through all those in detail, but everyone has their own proponents. We're still heavily BTB autograft or hamstring for secondary older patients. We do a little bit of quad, but I haven't been a real quad adopter, and I'll talk about that in a minute. And we use almost no allografts unless it's a really strange situation. I think ACL tunnel placement is something that we've talked about forever in orthopedics. I've been to every academy and AOSSM meeting since 1997, and every one has a big discussion on graft tunnel placement. You'd think we'd have that figured out by 2025, but I think there's still a lot of discussion. And the difference really is whether you go transtibial, which is the picture on the left, the schematic, or whether you go tibial tunnel independent, which means you drill through an accessory medial portal or medial portal. And the goal there is to get lower on the femur, and that's really been adopted by most surgeons over the last 10 years. So why do we still talk about that? Well, as I said, it's been debated at every meeting I've been at for the last 30 plus years. Freddie Fu in Pittsburgh did a lot of great scientific work on this, and his work was primarily talking about double bundle ACLs. But when he was studying this, he did a lot of studies looking at pivot shift control, so rotational control of the tibia and femur. And he found that the lower you went on the femoral wall, so a more anatomically low ACL, the better your pivot shift control. When I trained in Birmingham in fellowship, my two mentors were Bill Clancy, who's now retired, and Jim Andrews, who's also retired. Bill was a low femoral tunnel anatomic ACL guy, and Jim Andrews was a vertical transtibial tunnel guy, which is a more isometric graft. And I grew up doing both, but I really kind of gravitated towards the transtibial isometric, and we'll talk about why. But I started thinking about maybe I was doing the wrong thing back in about 15 years ago when Freddie was doing his studies. And I kept hearing at different courses that, going transtibial and going high on the femur was wrong, and listening to all the experts. And so I started kind of working with going low through the medial portal. What I found is that the ACL is certainly not isometric. The only fibers that are close to isometric are the anterior medial bundle, which is the blue in this figure, and the blue on the lower figure. So the anterior medial bundle is somewhat isometric. It's a little bit tighter in extension than flexion, but it doesn't have a lot of length change, whereas the posterior lateral bundle, which is where Freddie and others have been trying to put the graft more anatomically, has a lot of length change. In flexion, it's very close to the tibial tunnel, which means it's loose, and extension, it's very far from the tibial tunnel, which means it's tight. So you have to think about that if you're doing an ACL. So this is a study that Jeff Dugas and I published in American Journal of Sports Medicine, I think in 2016, looking at a CT scan of ACL footprint. So this is green thing is the footprint of the ACL in the typical patient. This is what it looks like when you do transtibial versus medial portal tunnels. So our transtibial is in red, and our medial portal is in blue, and this is with and without notchplasty, which is basically where you remove some of the tibial knots so you can see better. And what we found was that our transtibial went in the upper half of the footprint, and the medial portal went in the lower half of the footprint, but both were in the footprint, about 54%, so pretty similar footprint. It's just a different part of the footprint. So this is what it looks like. This is when you go low in the footprint. So this screw is on the lower part of the footprint, the posterior medial bundle. And you can see as the knee goes through range of motion, because the knee is a cam, the femur is not round, that the lower tunnel gets really close to the tibia in flexion and gets far from the tibia in extension. So as long as we put a graft in that acts like a slinky, that has a spring to it, then everything's cool. It springs short when you're in flexion, it springs long when you're extension, and everybody's happy. Problem is we don't have that graft. Everything we have is a very, very stiff material. So what we do is we go higher on the footprint, which makes it more isometric. So as you go through flexion extension with the higher tunnel, it doesn't have a lot of length change as you go through flexion extension because it's closer to the center of rotation of the femur. And so a more isometric tunnel, meaning it doesn't change length. So what happens when you do a low femoral tunnel and you're in full extension, the graft's in maximum tension, you fix the graft. Well, when you flex the knee at 90 degrees, it has some laxity. And most surgeons that have adopted the low femoral tunnel technique over the past 10 or 15 years have noticed this. When they put their graft in, they fix the graft in extension, they flex the knee up, and the graft is loose in flexion. And that might not be a problem in some situations, but in some positions, when you work in a bent knee position, such as a defensive player in soccer, such as an offensive defensive lineman in football, and you're always in a flex knee position, sometimes that can cause some laxity and some feelings of instability. So I'm not advocating this. This is what we used to laugh about in our meetings. This is a very vertical femoral tunnel, kind of straight up and down 12 o'clock position. That gives you no rotational control. What we're talking about is being at the high footprint, and this is the lower footprint, which is what most people are doing now in orthopedics. So Andy Williams, interestingly, just came out yesterday. Somebody sent me this from Sports Health this month. Wrote an editorial. Andy Williams is in UK, in England. He's probably the leading ACL surgeon in most of Europe. He deals with all the soccer players, the English national team, and a lot of the European soccer players, and does a lot of ACLs. And his editorial says, "Isn't it time to stop pretending that ligament reconstructions are anatomic?" And he goes further to say that, the center of the footprint you would think is the logical place to put an ACL, but actually most of the resistance to translation occurs in the anterior medial bundle, the more isometric part. And he himself says that after some time, he was convinced to do the anatomic technique. And when he moved his femoral tunnel, he had disastrous results. His professional soccer players' re-rupture rate got unacceptably high, and he eventually went back to his higher AM portal placement, which is what we've always done. So he recommended, and this just came out, like I said, in the last few days, realizing that biomechanically sound techniques are better than anatomically correct techniques. We shouldn't really use the term anatomic for ACLs and LCLs and MCLs because what we're doing is not really anatomic. It's more pseudo-anatomic. And we really need to test all of these. I think one of the limitations with Freddie Food's work on the ACL is that he was looking only at pivot shift. He didn't look at graft forces. He didn't look at failure rates. He only looked at the pivot shift phenomenon, which a lower graft was better at controlling. So what happens when you put a non-isometric graft in? Well, if you fix the knee, the graft of the knee in flexion, you end up with a tight knee in extension. You guys that are physical therapists have probably had this happen where somebody comes in day one after an ACL and they really struggle with extension. That's probably because the knee's overconstrained. The graft was probably fixed at 20, 30 degrees of flexion. It's not isometric. It can't stretch, and so it basically constrains their extension. And the only way you get extension is you've got to push the knee enough to move the graft in the tibial tunnel, or eventually they have a little bit of a contracture when they land in extension at 9 to 14, 15 months, they tear their graft. On the other hand, if you fix it in full extension, which I would advocate, you have good stability and extension, and they get full range of motion easily, but they're loose in flexion. And so for those people, they have a feeling of instability, even though their graft is intact. And those are the people that may benefit from an ALL or LET in my hands. And those are the ones that complain about some instability, but you look at their MRI and it looks perfect. And those are the people that have always driven us crazy. So this is a study just to kind of show you what happens. Brent Ponce was a UAB physician, not part of our group, and he asked if he could mine our database several years ago. This was published in 2016. And he looked at all the ACLs done at ASMI, and that was me, Dr. Andrews, Jeff Dugas, Benton Umblem, and Larry Lemack. There are about 3,000 ACLs over 5 years and 6 surgeons. And overall revision rate At follow-up time, 8 to 13 years, our revision rate was 2.3%. Pretty good numbers. But the most significant risk factor for revision was your choice of surgeon, which is really interesting. This is published in Journal of Knee Surgery. And the reason is we had one outlier. We had one surgeon that did a low medial portal, low tunnel, femoral tunnel, even back in the early 2000s. And he had a much higher failure rate. You see the revision for the first few surgeons was 1.8%, 1.3% revisions, and his revision rate was 5.1%. The only other outlier, number E, was a little bit higher because there were a lot of allografts. There are 162 allografts, which also have a higher failure rate. So the choice of surgeon was the number one variable that predicted a revision ACL surgery in our cohort. So how is the orthopedic world kind of reacting to higher failure rates? Well, I think denial has been the main reaction. I think the second reaction was adding ALL, LET, osteotomies, and other things because we figured the failures must be due to a capsular laxity problem. The other thing that happened, and it's pretty prevalent in the PT literature, is that we started making longer return to play times. We said, hey, minimum 9 months return to play instead of the traditional 6 or 8 months return to play. And then we found new grafts. So if your patella tendon tears, maybe you need more collagen. Maybe you need a quad tendon and more collagen. That's been promoted pretty heavily by industry. So in my mind, nobody's addressing the real problem, and that's that anatomic techniques that we've adopted are placing the graft in a pretty bad mechanical position with high graft forces and high failure rates. Just some quick studies. This is Australian ACL registry where they looked at delaying return to play. And what they showed, their conclusion was early return did not significantly increase ACLs. They had some that came back less than 9 months and some that came back after 12. The interesting part of this that they really didn't even mention is that their failure rate was 31 to 33%. It's crazy at 3 to 5 years. I mean, if that happened to me, I would be suicidal or out of business or not taking care of teams for sure, because there's nothing worse than seeing a patient re-tear a graft. ABS board review paper looking at randomized controlled trials, looking at ACL alone versus ACL with LET, showed that ACL alone had 12% failure rate and ACL plus LET had a 4% failure rate. Well, as I told you already, our failure rate, ACL alone, was 2.3%. And that was using a transtibial isometric high femoral tunnel, no LET, no ALLs, no osteotomies. So not going to show the whole surgical video, but our goal really is to get the ACL graft, especially patella tendon, in the high center of the footprint. We do a notchplasty to be able to see. We actually freehand our femoral tunnel, which just makes it easier to get in that position. This is a technique that Dr. Andrews taught me 26 years ago. Still a similar technique what I use now. And this is what an isometric graft looks like. So when you're in flexion, it's tight. When you're in full extension, it's tight. And it doesn't change. The bone graft doesn't piston in the tibia as you flex and extend the knee. That's opposed to a non-isometric graft, which is tight in extension, but you flex the knee up and you see that the femoral tunnel comes close to the tibia and you get this really lax graft. So it's tight in extension, but you flex the knee, and when you flex the knee, the graft, because the femoral tunnel comes anterior, it causes a lot of laxity in the graft. And this happens a lot on patella tendons with a low femoral tunnel. I think all of us have seen that have tried this technique. So Dr. Houston always said nothing like good follow-up to ruin good results. I think that's what's happening with ACLs, is that we changed our technique in a lot of ways about 10 or 15 years ago, and we really haven't had good follow-up. So I think we'll see this as we continue to follow it up, like Andy Williams did. So let's talk quickly about meniscus repair. I think, in standard of care these days is to save the meniscus. I understand why. I mean, the meniscus is an important load bearer. We all feel bad when we take a meniscus out on a young person, an active person. And some of these tears, like medial meniscal root avulsions, oblique tears, red-white tears, and even radial tears like this, have been promoted for repair recently. This was a Tom DiBordino Arthrex video that got sent to my email a while back, where he did 2 rip stops and a cross suture. And it's a pretty cool technique. I think it's a great job to fix that meniscus. But I would challenge anybody in orthopedics or physical therapy about whether that's actually going to heal or not. That inner surface radial tears in the avascular zone, and it may hold it together, but my suspicion is if you scope it in 6 months, it's still going to be torn. So the unintended consequences of meniscus surgery is that you can cause some DJD. The problem is we really haven't shown that by fixing the meniscus we can prevent the arthritis. It does make us feel better as surgeons. And a lot of patients come in asking for meniscus repair. I have patients every day that say, hey, I'm 75 years old and I've got a degenerative meniscus. Why can't you fix it instead of take the piece out? And I have to go through the physiology and, everybody's thinking down the right path, but I think we've kind of overcorrected and we're doing probably too many repairs, honestly. So what is the risk of repair? Well, a lot of risk surgically. The rehab risk, I think you guys that rehab meniscus repairs know that if you're non-weight bearing or you can't do your full range of motion, that's a risk, especially for older patients. And then there's some psychological risks and employment risk. I as an orthopedic surgeon probably couldn't work if I was non-weight bearing for 6 weeks. In the NFL and college football, it's a career changing risk in that you have a young person that's maybe on the fringe of the NFL or a college player that has an NIL deal and they miss a whole season, they may lose their ability to make a living for their family going forward. So how many surgeons or PTs have been non-weight bearing for 6 or 8 weeks? Not many of us, but it's pretty disabling. And I think oftentimes we obligate our patients to it without really discussing it with them. So just a quick case example. This is a SEC Division I linebacker who's 2017 freshman All-American, high round draft prospect, finished his freshman year. And right before his sophomore year in the summer, he started having medial knee pain and was diagnosed with a bucket handle fragment of his medial meniscus. And the team surgeon that I talked to later said, hey, my plan was to do a partial meniscectomy and have him back in 4 to 6 weeks when the season was starting and all would be good. The problem is they got into his knee and they saw this kind of deep oblique split of his medial meniscus and they said, hey, he's a young guy. Let's try to fix it. Surely can't be worse than taking it out. So they put 7 anchors in, 7 fast fix. He struggled. He was non-weight bearing for 6 weeks, missed the entire season. That next spring, he still couldn't play because he had a swollen knee, and they had 2 steroid injections, 2 HA visco injections, and he was sent to me for a second opinion. When the first time I saw him, I said, man, he's got an angry knee, swollen, angry, got a new MRI, and he obviously had a meniscus tear. And this is what he looked like. He had failed his meniscus repair. He had chewed up his condyle surfaces. Some of the implants had come loose and chewed up his condyle and ended up doing a chondroplasty. But really, at the end of the day, he ended up losing most of his meniscus and a lot of articular cartilage, and he really never got back. He came back that season, but he lost a step and didn't trust his knee, and in January 2020 retired from football. And this, again, was a first-round draft choice kid. So if I had taken out his meniscus or the team physician took his meniscus piece out, my argument is that he may have eventually gotten arthritis, but he probably would have played for a long NFL career before he did that and probably would have made a lot of money. It might have been a generational change for his family. This is what I call the jelly donut. Basically, it's a soft center meniscus. We see a lot in older patients, but we also see it some in younger patients. And people have come up with a lot of different techniques to fix these. I think of it like a jelly donut. It's got a soft center. I'm not sure putting stitches in it fixes that problem, but there's a lot of techniques to try to fix it. And that's some of the things that are being done now. So I think for meniscal tear treatment, be realistic about healing potential. Do what's best for the patient. We need to make sure they understand going in that if we make them non-weight bearing, it's a big deal. And we probably need to have that discussion before we decide to fix their meniscus. First, do no harm is kind of our mantra in medicine, but sometimes that means removing the meniscal fragment, not trying to repair it, even though you think you need to save the meniscus. So in conclusion, 6 rings and counting for me, hoping for another one someday. It's been 5 years, it's been a long time. Hopefully we'll win again soon. ACL reconstruction can provide functional stability using several different graft options. With any new idea or technique, critically evaluate the concept. Don't just follow the leader. Just because one of the mentors in medicine say it's the thing to do doesn't always mean it's right. I think some people are using ALL and LET to overcome a poor ACL. The other reason to use it in my hands is for a non-isometric graft. Meniscal preservation is the goal, but be realistic. Some tears in types of locations actually need meniscectomy. Now, I think as a physical therapist, you guys need to communicate with your surgeons about what they like and why they like a quad tendon versus patella tendon versus hamstring. If you notice that there's difficulty with extension, I think that's really a discussion that you guys should have, because as surgeons, oftentimes we don't see our patients back 3 times in 3 months after we operate on them. You guys see them every day, so I think communication is really important, and please communicate with us as surgeons. Thank you.
That's great, Lyle. Excellent presentation as always. Got a couple quick questions for you, if you wouldn't mind, as we change the PowerPoints. One is Laura's asking, what do you do with a revision? What do you do with the tunnels?
Yeah, great question. So I think it depends on what the primary surgery was. Um, Bone, tendon, bone, or any kind of bone primary procedure, there's really no incidence or risk of of tunnel widening. Everybody worries about tunnel widening. Tunnel widening really only happens with soft tissue grafts. And so if the patient has a primary hamstring graft, quad tendon graft, allograft, soft tissue, tunnel widening can be a problem. And so a lot of people have advocated doing bone grafting of the tunnels and staging a procedure. The reality is if you're going to use patella tendon as your second surgery after a soft tissue procedure, you can actually use the bone plugs that you harvest for the ACL graft to graft the tunnel at one point. So you can do a single stage bone grafting. The other thing that comes into play is if you have previous tunnels that you're not really favor of where the tunnel was, sometimes getting around those tunnels can be difficult. And so there are occasions where we use additional bone graft or we'll put a screw in a tunnel and fill it so that we can put our graft where we want it to be. And those are really the complexities of revision surgery is figuring out where you want to put the tendon, the new graft, and what to do with the old tunnels.
What what's your placement, just to be clear, on the femur? I would say the left knee.
Yeah, so if it's a left knee, so your clock face is kind of 1 to 6 o'clock. The footprint really is the entire way. I mean, if you look at the footprint, it starts at the what we call residence ridge, which is a ridge on the that goes from the top to bottom of the femur, and it goes all the way from the top of the notch to the bottom of the articular surface. So it's a big elliptical area. We want to be in the top half of that. So I'll drill at say the 1 o'clock or 2 o'clock position, 1:30 position, realizing that with a patella tendon, my bone plug is at the top of that. So the graft's not there. That's the bone plug in front of that. So the screw may be at 1 o'clock, the bone plug at 2 o'clock, and the graft is actually at 2:30. And so it's a high tunnel, but the graft is right in the lower part of that. The opposite would be if you do a low tunnel, let's say 4, 5, 6 o'clock, or even 3 to 5 o'clock, and you put a patella tendon graft in. Most of us put the bone plug anterior, the screw anterior, and the tendon is on the posterior edge. That puts the tendon way down at 5 o'clock, or on the lower part of the femur, depending on how you look at it. And that's where the cam is that rotates back and forth. So as long as the tendon's in the upper half of the footprint, I think you're probably okay. If you're using a soft tissue graft, hamstring or quad, it fills more of the tunnel. A patella tendon is a ribbon. It's thin. It's probably only 3 or 4 millimeters in the AP dimension, but 10 millimeters medial lateral dimension. So you're putting a ribbon in. With a hamstring or quad, you're putting a rounder tunnel in. So you've got a little bit more freedom, a little more leeway to be off on your tunnel.
Two-part question. You think if somebody misses tunnel placement, they usually miss high? And then second is, you think with the two incision procedure years ago before endoscopic, you think that tended to be a little bit lower? Not lower than it's supposed to be, but tended to be not as high?
No, I think the opposite, really. I think the two incision tends to be higher because the way that they did that is they made an incision and hooked a guide behind the knee, which really ended up being kind of at the top part of the notch. So it was usually a higher tunnel. I think in today's world, most people that miss probably miss low, and they miss because they're doing through a medial portal or a flip cutter, which is a device where you retroream. When you use a device that doesn't require you to go through a tibial tunnel, it's easier to miss low than it is to miss high. And the reason is that as you flex the knee and you start reaming, it tends to err a little bit lower towards the articular surface in terms of its placement rather than high in the notch. It's probably harder to do a high tunnel using a retroreamer, flip cutter, medial portal, just because your purpose for being there sometimes is to go lower.
This is a question for both of you. Robin, if you want to jump in. Bear procedure, your thoughts. Everybody always asks this on our webinars and meetings.
You go first, Lyle.
Okay. Yeah, I mean, so Martha Murray developed the Bayer procedure, and I think I've seen the presentation many times over the last several years, and great procedure, great outcomes. I think it was kind of initially developed for the pediatric population and for a low demand population. It's been kind of stretched to be more for all comers. I think it really, ACL repair in general, not just the Bayer procedure, is probably better for very certain tear configurations and tear types and activity levels. I think in 2025, it's still probably not made for the high school athlete that has a mid-substance tear. I think it's probably over thought or over promoted, not necessarily by Martha, but just because people have learned to adopt it. And I think it's a great, I think ACL repair itself is a great idea. And if we can make it work at a high rate, it's probably better than a graft because it is more anatomically correct. But I think the Bear procedure is really for very specific certain circumstances that are not super common.
Yeah, I totally agree, Lyle. And the literature early on showed good results, but now as you start to follow out, 2 to 5 years out now, the results are not as good, and especially in these high level athletes. So I think like you said, it's finding that right patient. And she really advocates for that mid-substance ACL tear, which I don't do a repair on. I'll consider a repair on an older patient, maybe who's not as active, who has a femoral sided injury, and they're having instability with ADLs, and then I think that's a great person to do a repair on. But I
Yeah,
don't do the bear.
yeah. The other side of that is sometimes a really young pediatric patient, like a 7, 8, 9-year-old that has a femoral avulsion. I've repaired those just using suture anchors back
I
in the
mean,
day before
yeah,
we had all that. And I think if you can get the thing close to the femur in a pediatric patient, sometimes they'll heal because they grow new limbs like a lizard.
I totally
Um,
agree. Those are the ones I repair them on the wide open growth plates, and they have a
yeah.
femoral sided injury. I believe that as well.
This is a question for both of you, then we'll move on. How do you define a successful outcome after ACL surgery?
Yeah,
Go
it's
ahead.
interesting. I mean,
Yeah.
I think that's a great question, Kevin. I think that obviously the patient outcome, right? It's a combination of their physical and mental recovery, and can they get back to what they want to do? So you're looking at a high level athlete. Can they get back to what they were doing beforehand, and maybe even better? That's successful. But there's a mental component also. And if you look at our literature, that only 65% of patients really get back to that high level. So you look at professional, NFL players and their return to play rate. And we always say, oh, it's successful. Your knee's stable. You have no swelling. You've got full range of motion. You passed all our testing. But why aren't they back to playing? And only 65% of patients are going to get back to that same level they were at before. But that's probably because of fear, and that has a big aspect of the recovery. So I think that again, getting back to what they want to do is successful.
Well, you had Alabama football players that were fearful.
If they are, they transferred.
Where did they go?
Yeah.
I mean,
Keep your
it's
name
it's
in
it's
school?
weird in the NFL, right? I mean, if you look at that data, that 65%,
Yeah.
and that's data that's been around for a long time, and that's
Yeah,
and
that
so
data came from our group, which really shocked me because it's interesting. Looking back at that data, I mean, it was published, it's been probably 10 years ago now, but I can't think of a player that didn't make it back. I
I
mean,
didn't read of any of them that didn't make it
that's
back, just
right.
to
That's
make
right.
it perfectly
But
clear.
yeah, I can't think of an individual that I remember that we did that didn't make it back. When you look at it, the biggest risk factor in the NFL was lower draft choice or
yeah,
free agent. And
right.
so the guys in the top 4 draft rounds make it back because the team's got money invested and they do,
Yeah,
they may not be quite as good, but they make it back. I think,
and they're better
success for
athletes,
me,
right?
yeah, exactly. I mean, success for me, I did an ACL on my partner who's 17 years ago, 2008, when he was a resident, tore his ACL wakeboarding. And I asked him the other day about it, and he said, "Yeah, I can't even tell which knee it was. I have to look down to find my scar." So I think, having a normal functional knee is really important. The thing that we haven't conquered, and part of my whole point of my talk is that the theory behind the change in ACL technique with Freddie and everybody did 15 years ago was that better pivot shift control equals less arthritis. And the reality is nothing we have done, ACL, perfect surgery, perfect function, perfect return to NFL play, a knee that they don't even know is different than the other knee still hasn't shown that we can prevent arthritis later on. And maybe it's the chemicals that are released when you tear your ACL, maybe it's the chondral damage, maybe it's meniscus. There's a lot of factors involved, but ultimately the perfect ACL would be one that prevents arthritic changes later, and we really haven't proven any of that later. So I think that's the misperception in the community is that most patients think they get their ACL fixed to prevent arthritis, and that's not really true.
Well, I think we've got to move on in the interest of time, and we've got some more questions that we'll get to later. So keep them coming in, everyone. So I want to hand it over to Dr. West now. She's going to talk about tibial slope corrections as well as LETs. By the way, a couple of questions came in. LET is extra the extra-articular tenodesis, as you see here, and ALL is the anterolateral ligament for the two questions that were asked. Dr. West, it's all yours?
Are you guys able to see it?
Not yet.
All right, let's see. Hold on. Thought I had it shared. This is sharing. Let's try it one more time here. Can you see that?
Yep, there we go.
Okay. I'm going to put it in. Let's see if this works here. Does that work? No.
Nope.
Okay, so we'll just do it the regular way. Sorry, you guys. We'll go back. Do it this way. Is that working?
Yep, great.
You can see that. Okay, great. All right, so I'll be talking about slope-reducing osteotomy, lateral extra-articular tenodesis, and ACL graft choices. So in overview, since Title IX in 1972, there's been a growing trend of ACL tears in female athletes. I'm not focusing on female athletes, but unfortunately, my practice and where I am in DC, I see a lot of female athletes. So females have an 8% increased risk of ACL tears, as you know, and there's a 22 to 30% rate of a second ACL. So after a primary ACL reconstruction, a re-tear of up to 30% in female high school soccer players, and that's a study out of Mayo Clinic. So that's either ipsilateral or contralateral, and so we really need to mitigate these risks. And we look at risk factors for ACL tears and for failed ACL reconstructions. And I know Lyle talked about some of the anatomical issues, biomechanical issues, but there are these non-modifiable and modifiable risks. The non-modifiable ones are that we can't change. Hormonal changes that female athletes go through, developmental changes, biological, the age of the patient, anatomical, having a narrow intercondylar notch, a shallow medial tibial plateau. And then there are modifiable ones. And the modifiable ones are the neuromuscular ones, and you'll probably talk about those, Kevin, but quad dominance, landing mechanics, and those are things that we can potentially modify. And so when I look at a failed ACL, and again, the practice that I have now has really grown into this very high level of female athletes, high school, collegiate, and professional athletes, and I see a lot of revision to that are sent to me. And so when I'm looking at a revision and why did the ACL fail, I think about what Lyle was talking about. Was there a technical error, tunnel position? Was a tunnel too anterior, too superior? What kind of graft choice was used? We know that hamstring autografts have a higher failure rate, especially in female athletes under the age of 20. So when we're looking at that graft choice, the graft maturation, was that player, when were they getting back to play, and were they ready to return to play? Was the graft mature? And the rehabilitation side is important. The loss of motion, weakness, and again, loss of motion can also be tunnel error, or technical error, and how you tighten the graft, where you put your tunnels. So those are all play a role as well. Alignment, bony alignment, looking at somebody's varus valgus alignment, and we'll talk about the tibial slope and the posterior tibial slope, how the slope of the tibia lines up. I don't know if you guys can see my arrow, but if we look at the tibial slope, we look at this, the angle of the tibia, the proximal tibia, to the length of the tibia here. And so the slope, when it goes backwards, that's what the tibial slope is. And I'll show that on some other slides. And then finally, hyperlaxity may play a role. Hyperlaxity is when you have a large pivot shift. Let's say you just tear your ACL and you do a Lockman like Lyle was showing in a pivot shift, and they have a very large pivot shift. And that may be also a risk factor or a reason why they failed their ACL. So when we're looking at why patients failed, and if their tunnels look like they were in good position, and their meniscus are in good condition, and they have normal cartilage, what else can be the reason? Again, those were the risk factors we looked at. So this lateral extra-articular procedure, or the LEAP procedure, which is a lateral extra-articular tenodesis, was studied in the early 1930s, and that's when the first concepts started. And what it is augmenting the anterior lateral complex of the knee. So augmenting the IT band, the anterior lateral ligament to reduce rotatory laxity, anterior tibial translation, and the pivot shift by controlling internal tibial rotation and offloading the ACL. So again, this concept started being developed in the 1930s. Modifications were made in the 60s and 70s. And then people started getting worried about over constraining the knee and over tightening the knee, because again, you're reconstructing the lateral side of the knee. So it's like a secondary stabilizer or an external brace. And if you, again, there's some concern about over constraining and over constraining that lateral compartment. So then its use started decreasing. But then there was a rediscovery of the anterior lateral ligament in the 2010s. And people started looking at it more and studying more. And then the stability trial came out. The stability trial was published in the American Journal of Sports Medicine in 2020. And they had 618 patients. These are high risk patients. These were all elite athletes under the age of 25. And what they did was they did a hamstring ACL reconstruction on them. And hamstrings, we know, have a higher failure rate. In this study, they had an 11% failure rate just doing the reconstruction alone. But when an LET was added in, when a lateral extra-articular tenodesis was added in, that failure rate decreased to 4%. So all of a sudden it became very interesting. Maybe you can add this in when you're using a hamstring graft on these elite athletes. And so they changed the terminology. Again, there are all kinds of things you can do: reconstructions, IT band weaving, but basically they all fall under this lateral extra-articular procedure, or the LEAP procedure. And so different techniques were developed: the Lemire, McIntosh, Ellison, and the anatomic, the ALL reconstruction. You can see all these procedures here on these drawings, but the most common is really the lateral extra-articular tenodesis, which you can see in this diagram here. This is where you take a strip of the IT band, kind of that middle portion of the IT band, about a 7 to 8 millimeter width, and you leave it attached to Gertie's tubercle, and then you detach it about 10 centimeters up, and you detach it, and then you weave it under the LCL, and you attach it to the lateral femoral cortex with either an anchor or a staple. And by doing that, again, it's a secondary stabilizer. And so there was an international consensus statement that just came out this year, and they've recommended it now for patients, high-level patients, playing at high-level sports, ages under the age of 25, playing pivoting contact sports, who have a large preoperative pivot shift and high-grade laxity or rotational laxity, and generalized hyperlaxity. It can also be considered for revision ACL reconstructions, or if you have a deficient lateral meniscus, or a second fracture, or a anterolateral capsular injury. And we look at all these studies now. This is crazy. This is over the past 6 years. All these studies have been published now. Again, looking at all these studies, the rates of revision, or the rates of failure, have decreased significantly. And so when we talk about it, and we talk about all those studies, what we find is that the primary ACL graft in all these studies was a hamstring graft. And again, I told you there's a much higher failure rate, but all these studies, about 80 to 90% of the cases were done with a hamstring autograft. About 10% of the cases were done with a BTB, and these were mainly observational series. And the quad tendon was done more recently in these cohort studies. So really the takeaway is that the graft failure was certainly decreased in these high-risk athletes, but using almost a high-risk graft. So they had improved rotational and subjective stability, higher return to sport rates. There was no increase in complications or osteoarthritis at the midterm follow-up. And so this was an evidence-based adjunct, or an addition, for these high-risk profile patients. And again, the strongest study was Stability 1. Stability 2 trial is coming out in 2 years, and that trial is looking at quad tendon and BTB grafts as opposed to hamstring. So that's being randomized. But again, this Stability 1 trial that was published in 2020 used the ACL reconstruction with hamstring and the IT band lateral extra-articular tenodesis. And so this is really evidence supported because this construct, because of the reproducibility of it, the graft availability, because again, having hamstrings and the IT band, they're right there and they're easy and low morbidity. But again, when you look at the benefits of using it for a BTB or a quad tendon graft, the results don't show as great of a magnitude as they do for the hamstring. Again, because those failure rates are much lower than hamstring. So just something to think about. This is the procedure. This is an LET. Again, so we're taking that strip of the IT band, and you leave it attached distally at Gertie's tubercle, and then you detach it proximally. and then you strip it off, and you can see here, and then you pass it under the LCL, and then you fix it right to the lateral cortex. And so by doing that, there are different ways to do that, and you can tighten that down. You can actually over-constrain the knee by tightening an inflection and by putting a lot of tension on it and fixing it down, because again, then it's difficult to gain that extension. And so I've seen a lot of issues where this can be over-tightened. Patients have difficulty gaining that extension, activating their quad after surgery. So this is not just a simple surgery. I think that companies have made it simple in the sense that now it's easy with certain anchors, and it's an easy technique to do. It adds in 10 minutes to the case. So it's done very frequently because why not do it? But again, there are risks with it. And so we have to just be careful technically with it. Now we'll talk about the slope reducing osteotomy. So this is what I was talking about. If you look at this picture here, you can see that the posterior tibial slope here, and then you can see the reducing osteotomy. What you do is you take a wedge of bone out to reduce it and then to make it flat. So basically the posterior tibial slope increases the anterior shear force when the knee is weight bearing and has knee flexion. And that increased anterior shear force increases the anterior translation and puts excessive stress on the ACL, and that predisposes to primary and secondary ACL tears. So if you can decrease the slope, you can decrease the anterior translation and reduce the graft load. So the indications for a slope reducing osteotomy are recurrent ACL graft failure. So somebody who, unfortunately, I do see a lot of these in my office, patients are sent to me after 2 or 3 ACLs, and they've come to me now and they're here and they have good tunnel placement. They don't have anything else that I can find that needs to be done, but I measure their slope and they have a 13, 14, 15 degree slope. And so that's a consideration to do a slope reducing osteotomy. And here's some biomechanical information. So biomechanical effects. So we talked about the decreased anterior tibial translation. If you're doing a slope reducing osteotomy, it can decrease the graft strain, and it can decrease the pivot shift and anterior instability. The clinical effects is obviously it can improve stability after a reconstruction or a revision surgery. It can lead to reduced re-rupture rates, especially when the slope's over 12 to 13 degrees preoperatively. It enables the return to pivoting sports with a lower failure rate. But again, the considerations also, we have to think about the risks of it. Overcorrection can lead to posterior instability. It also leads to hyperextension. So if you have someone with a lot of hyperextension, and then you're going to do this and increase their hyperextension, that may be a consideration as well. And you have to be careful with this. You have to do this very, very precisely because, again, there's a hinge point. You can see the osteotomy here, and there's this hinge point posteriorly that you do not want to crack through. Otherwise, you're going to destabilize the proximal tibia. And so there's a little slower initial recovery due to bone healing. So I'm actually pretty aggressive about it. I like Lyle. I believe in weight bearing and getting patients moving right away. So I do a very limited amount of non-weight bearing. I'll do toe touch weight bearing for a couple of weeks and then progress them. So that initial recovery is a little slower, but that long-term recovery is about the same. And we look at this. So these are some studies. I just wanted to talk to you about the tibial slope. And so a 20-year study out of Australia, they looked at ACL graft survivorship in adolescents with a mean posterior tibial slope of over 12 degrees. And they found that only 22% of these ACL grafts survived at 20 years. So that's pretty bad. Then we look at the elevated posterior tibial slope. This is obviously a significant risk factor for revision ACLs and the failure rate. So patients with a posterior tibial slope of over 14 degrees had an 18 times increased risk of a failed revision ACL reconstruction. And there's also a significant highly positive correlation between the slope, the posterior slope, and the graft force. And you can see that here on this picture. If you look here, as the tibial slope increases, you can see that the loaded graft also increases. So again, when you're reconstructing the knee and you have an increased slope, this is something to think about. So in vitro biomechanical studies show that a slope-reducing osteotomy results in a significantly decreased load to the graft as well as anterior tibial translation. And now we talk about primary ACL. So what happens when you come in with a high-risk patient, a female athlete who's playing at the elite level, a soccer, lacrosse player who has an increased posterior tibial slope? These are high-risk athletes. So this was a study looking at 18 patients who are high risk, and this was just published in 2020, and they were done primarily. So primary ACL reconstructions who had an increased slope of 13 degrees. They had increased tibial translation, and some had a chronic posterior horn meniscus tears. And what they did was they did a primary slope-reducing osteotomy with a primary ACL reconstruction. And at 2 years, all these patients were able to return to their pre-injury activity level, no graft ruptures, improved outcome scores, and clinical exam. So this is something to think about when we have somebody who's high risk. Again, I mean, Lyle said there are lots of other things to consider as far as tunnel placement, but maybe we want to think about these secondary factors in these high risk patients. Now we talk about revision ACLs and slope-reducing osteotomy. So these patients who are coming in for revision have a lower return to play rate anyway. But this was a series out of AJSM in 2023. It was 64 athletes who had already undergone one revision ACL reconstruction. Now they're coming in for their second. And they had an increased slope of over 13 degrees. And they were able, they got 48% back to return to play. The re-tear rate was low, as 4%. But as you can see, the return to sport was relatively low at 48%, and return to pre-injury level was 25%. But again, that re-rupture rate was low. So how do we do these osteotomies? So when we look at this, we have to figure out what kind of osteotomy to do. There is supratubercle. So the tibial tubercle, here's a patellar tendon coming down and inserting. So you can go above the tubercle, you can go through the tubercle, or you can go infratuberosity. I prefer to go supratubercle, and the reason I do that is because you have this nice cancellous metaphyseal bone. It's going to get good healing right here, and you can get compression right across it, and I can weight bear my patients right away. When you're starting to go into the diaphysis, the healing's a little slower. You need more stability. You need a big plate. And again, this proximally, you can just use some small staples for fixation. Osteotomy planning is tricky. You have to get x-rays, measure the slope of the tibial slope, and the goal is to get them down to 6 or 8 degrees of a tibial slope. You don't want to overcorrect them. And then you also want to measure the patellar height, because again, if you're going to go infratubercle, and then all of a sudden you're going to change the tibial height, depending, actually any of the slopes. So if you even go above the tubercle and then you do a slope reducing osteotomy and you take that wedge out, then all of a sudden you'll get patella baja. So those are things that you have to think about as you're doing this. And this is a patient of mine. He was a basketball player, a collegiate basketball player, and he came to see me for his third ACL. He had failed. He had already had one primary ACLs and failed 2 revisions. So he was coming to me actually for his 4th ACL. And he had a slope of 15 degrees, and everything else looked good in his knee, actually. So I did a single stage. I did a slope-reducing osteotomy and an ACL, a revision ACL on him. And so you can see I did a contralateral I did a quad tendon on him. So I did a quad tendon harvest, and then I did a slope-reducing osteotomy. But here, what I do is you can see I mark the angle of the osteotomy. So this is, again, supratubercle here. This is the wedge that we're going to take out. He was 15 degrees. I was trying to correct him to about that 5 to 6 degree angle. And so you can see here, this is how we do it. We mark the angle, that pivot point. We take our saw, we go across it, and we take out that wedge. And then we bring him into hyperextension. And then we close that wedge down, and we use staples. And these staples are nice because, again, they're out of the way. I can drill my ACL tunnels. I can do this all in one stage. And so here his pre and post-op x-ray. So his preoperative x-ray is a 15 degree slope. And then his post-operative x-ray at a 4 degree slope. And so again, the post-operative plan, I typically will do that non-weight bearing, a toe touch weight bearing for 4 weeks and then progress them. So they're out of the brace, their weight bearing is tolerated, they're increasing their activity at 6 weeks. And then again, that return to play rate maybe is a little bit longer, but not much longer than a standard primary ACL. Now we're going to move on to graft choices. Kevin asked me to talk about my favorite graft choices. So I thought I'd just start with some things we think about when we talk about graft choices. Obviously, we have our autografts and our allografts. I'm a fan of autografts, so I rarely use allograft. I think about bony incorporation, how quickly can we move someone, how the fixation is. So we know that bone heals quickly, right? BTB, a bone tendon bone graft is going to heal quickly. Within 6 weeks, that's going to be healed. Quad tendon or hamstring grafts are going to take longer to incorporate in the bone. They're going to take 3+ months to incorporate. And allograft has been shown to take over a year to incorporate in the bone. So allograft is really not not my favorite graft because again, it can early on you're going to feel okay, but are you going to be able to get back to your level of activity? And then graft maturation, we have to think about how does that graft mature? You know, the intrasubstance, the part in the knee. And so if we look at this study, this is a study from 2011. And so if we look at this, animal studies and human studies and looking at how does the maturity of the graft, how long does it take? It takes a long time. You can see this whole process. It takes about a year to really mature. But really that average time frame is 18 months if you look here. So, you know, we talk about getting people back here at that 6-month time frame. Are they really ready? You know, this is when it's going through the remodeling phase. This is something to think about as we start to allow our athletes to do more and more. But again, that BTB is going to heal quicker in the bone and be a little stronger early on. We talked about the rehab side of it. So the quad tendon graft has really grown in popularity, and I'm going to show you a graph of this, but it's grown tremendously, and I think it's grown tremendously because again, these companies are making easier techniques, harvest techniques, fixation techniques, and so as these companies have published or have produced these types of implants, all of a sudden that quad tendon graft has become really popular. But the concern still is that the quad tendon graft really leads to significantly reduced quad strength. And this was a cross-sectional study evaluating quad strength in matched controls, quad tendon, BTB, and hamstring grafts at 7 months post-op. So it's still pretty early on the rehab side, but you can see that quad tendon grafts were significantly lower limb symmetry index for all variables when they were compared to hamstring tendon and BTB. And none of the grafts reached LSI of greater than 90%. Now, again, this was only at 7 months out, but still concerning. Now we look at hamstring autografts. So hamstring autografts obviously lead to significantly decreased hamstring strength. And we know that weaker hamstrings leads to higher risk of ACL injuries, especially in female athletes. So that's always a concern of mine. But this was a randomized control trial with an 18-year follow-up. So it had a very long follow-up. And in 18 years, they had 46 BTB and 49 hamstring patients. And flexion strength was significantly decreased, even at this far follow-up. So you can see that mean total flexion work was reduced by 17%, and the mean flexion torque was reduced by 10%. And you can see the BTB side was really almost normal, right? And the hamstrings were very low. Then we look at BTB and hamstring grafts now. So these are the most common grafts, right? Before the quad tendon was really gained popularity about 5 years ago. So these were 160 patients randomized to BTB or hamstring, and they were either in the accelerated or the standard rehab protocol group. They were tested at 4 months, 6 months, 8, 12, and 24 months. And there was no difference in outcomes with rehab protocols, but there was a persistent long-term significant flexion deficit in hamstring autografts, and you can see these in all these graphs. But there was this early quad deficit in the BTB graft at 4 months, but then that normalized as you got to 8 to 9 months. Now we look at the recurrence risk. So we look at the Moon study this was from 2011, and you can see allograft versus autograft. So look at this allograft rate. This failure rate is significantly, under the age of 20, you have almost a 25% chance of failing if you have an allograft. So that is incredibly high. And then you can see that drops down, but it's still higher. Even into your 50s, it's still a higher rate. So this is why I always prefer using an autograft if I can. Then we look at the Kaiser Permanente, the registry. They had 22,000 patients, and looking at hamstring, quad tendon, and BTB autograft ACL reconstructions. And what they found here, you can see this, that there's a statistical significance was 1.5 times revision rate for the hamstring autograft. So again, we look at the failure rate of hamstrings. Now we look at patient-reported outcomes, and there's no difference in patient-reported outcomes complications for quad tendon and BTB grafts in a retrospective study. But if you look at this study out of arthroscopy, it was a prospective study in 2024. These are older patients over the age of 50. and they looked at quad tendon and hamstring grafts, and they showed no significant difference at 2-year follow-up. Again, at a year follow-up, we saw that quad tendon causes significant weakness, and I do see that in my older patients. If you do a quad graft, it just takes much longer and it's much harder for them to recover. So when we look at this at 2-year follow-up, they have equal outcomes. So I just wanted to show this graph to you. You can see this is looking back from 1992 up until the most recent, and you can see that patellar tendon grafts were very popular, and they're starting to get less and less popular. This is an international graft, international usage. You can see hamstring is increasingly becoming more and more popular, and again, as LET has become more popular, hamstring grafts are again gaining popularity. Quad tendon, you can see it gained some popularity. It started going up, and then in the 20s it started to go up a little more, again, because the technique became a little easier. But these are my preferences. So in a patient with closed physes, so an adult or a high school kid, elite athlete, BTB is my graft choice for many reasons. It has the best fixation. It's proven in high demand sports, preservation of hamstring strength, quick bony integration, proven track record. It's versatile. And you can address it anterior knee pain with good rehabilitation. So I always, if I have somebody who I'm concerned about, I'm always in touch with the physical therapist, again, working to make sure that we're mitigating that risk early on and they're not coming to me 6-7 months out afterwards with anterior knee pain. Open physis, so patients who come to me, I do treat a lot of pediatric patients, so the 10, 11, 12-year-olds who come to me with open growth plates. Either I'll do a repair like we were talking about with Lyle if there's a femoral sided avulsion. But if you have a mid-substance tear, I'll do a quad tendon autograft because that can avoid a physeal injury. It has good outcomes in adolescence. Again, that early quad weakness is concerning, but if you have to get that physical therapist or get them engaged with a really good physical therapist and start activating that quad as soon as I have them in the recovery room doing leg raises, actually. So the nurses always laugh at me. And then for the older and lower demand patients, I prefer doing a hamstring autograft. An allograft, again, we'll consider that if there are other risk factors or they have significant arthritis and instability. But again, that hamstring autograft has less anterior knee discomfort. It's much easier to recover from early on. So in conclusion, ACL tears and graft tears are multifactorial. Obviously, we have to mitigate these risks by addressing all these modifiable risk factors that we can. The survival of an ACL graft is shorter in patients when the posterior tibial slope is over 12 degrees. And there's an 11-fold increased rate of a failed graft after a reconstruction, so a revision, when there's an increased posterior tibial slope of over 12 degrees. We know that the lateral extraarticular tenodesis reduces graft force and pivot shift, but a slope-reducing osteotomy should also be considered when there's an elevated posterior tibial slope. So this graft choice requires many considerations: age, growth plate status, activity level, prior injury, history, access to rehab, and patient expectations. Thank you.
That was fantastic, Robin. Thank you so much. We've got some questions. So you had said that 12 degrees or more was a slope that you're considering corrections on. What is the optimal slope? What is the perfect slope of the tibia?
Perfect slope is 6 to 8 degrees, and that's what our literature shows. So we aim to get to that when we're doing an osteotomy. Again, the hard thing is, Kevin, I said when somebody comes to you and they have a 14-degree slope and they're a female athlete, they're playing at a high level, and that's a primary ACL, are you going to do that primarily? I'm not there yet. I still believe in picking the right graft, doing the right surgery, putting the tunnels in the right position is the best primary option. But when somebody comes to me after one or two failed ACLs, I'm considering that osteotomy.
With extraarticular tenodesis, do you see an increased incidence of IT band syndrome or pain in addition to that, with the addition of that surgery?
I don't. I do it a lot. Actually, I'm doing it a lot more frequently. And I'm doing it more frequently. I think, again, it's just the area that I'm in. People are coming to me, very educated patients who come to me and are asking for it because they've read the stability trial. They're looking at stability 2 is coming out, and maybe there's a slightly increased or decreased risk of a re-injury. So patients are asking me for it now. And again, I've been doing more and more, but I do not see IT band being an issue, short or
I
long.
think, yeah, I think sometimes with swelling on the outside, and you can put a little pressure on the IT band, they complain of it that way, but I've never seen I'm sorry, iliotibial band problems from an LET.
Yeah.
What percent of your patients would you say for primary and then revision get an LET right now?
I do a lot of these high level athletes and high risk athletes. And so I'd say that most of them, I look at the criteria. So I look at, are they hyperextenders? Are they hyperlax? Female athletes, pivoting sports. If they meet the criteria, they're going to get an LET. Um, so I'm moving that way. So even though I'm doing a BTB, which obviously has a lower failure rate, why not mitigate every risk we can?
So on a revision, you
On a
don't
revision,
routinely
I'd say
do it. It's
most
all,
people, yeah, on a revision, I'm looking at everything I can. So I'm looking at their slope. I'm looking, going to do an LET or a slope reducing osteotomy. I'm going to do something else because they failed once. Now, if they failed and they came to me and their tunnels are poorly placed and there's an obvious reason for their failure, then I may not do it. But if somebody comes to me and they've had well-placed tunnels, they had good rehab, and then they failed, and then now they're 12, 14 months out from their primary ACL, I will add in something else.
and then tibial slope correction. If you do it on one side, the question is, does it put the person at a predisposition for the contralateral side to have an ACL injury?
Yeah, there hasn't been any studies looking at that actually, and it's a small correction, and so that has not been looked at, and I don't think it is currently being looked at, but it's an interesting thought.
So do you do bilateral x-rays on these knees to see the slope on both sides?
I do. Typically, that slope is a little higher on that ACL side.
Is there a family predisposition to a slope?
Yeah, that hasn't been studied either, and I wonder, but again, it's usually different than the other side. It's usually increased, and and I know that bilateral ACLs are common, right? There's a risk that you're going to tear the contralateral side. But why did you tear that first side initially? Is it obviously there are lots of anatomic risk factors, but that might be one.
Yeah, I had a girl come in today one day post-op, had surgery yesterday, contralateral, it was a revision, contralateral patellar tendon with an LET, came in with her parents. Mom had two ACLs, dad had one, and this is her second ACL on the
I
same
see it all the
side.
time.
Yeah, exactly.
Yeah, or families like I have a family of three girls and they all play collegiate soccer and I'm like, oh, I've done
Yeah.
bilateral on two of them and the little one, she's in high school and I'm like, oh, just yeah.
In patients with, and I think Lyle's still on, so Lyle, jump in on this one as well because you're a big patellar tendon guy. In patients that have patellar tendinopathies, would you still choose a patellar tendon graft or would you go to the quad?
Yeah, I'll do a patellar tendon graft. I will actually I do look at that because the question is how much tendinopathy do they have and do they have a big ossicle or do they have because the concern is if you fix the bone plug in and then the tendon's not really attached, right? If you have a 50, 60% injury at the patellar insertion, then it's probably not a great graft choice. So I'd look at how much involvement there is, but I certainly do it. And as I'm sure Lyle will tell you, most of the guys he takes care of have tendinopathy or had an Osgood Schlatter. But the question is, how big is that ossicle also at the tuberosity?
Yeah, that's a great question, Kevin. I think the advantage of a patella tendon graft with patella tendonitis is that it cures the patella tendonitis. The surgery that we do for patella tendonitis, if we're going to operate on it, which I try to never do, but if you have to operate on patella tendonitis, the surgery is to harvest that central third generally and repair the other pieces back to the patella. And so when you take that central third graft, as Robin said, sometimes you worry about the attachment. If I feel like there's an ossicle there, I'll shell the ossicle out. If I feel like the attachment's not great, when I use my sutures that I'm going to use to pass my graft, I'll pass the sutures through the bone and through the tendon and try to kind of tie that together to give it better fixation. So I usually don't shy away from patella tendon just because they have tendinosis. I think it actually cures two problems. So it's kind of a nice side effect.
Yeah, I agree with that. And again, I do the same thing. I'll put the sutures through the tendon and then pull it through the bone plug. So if there is some detachment of that proximal insertion.
So last question, and then we'll move on. This is for both, or whoever wants to jump in. This is kind of an interesting question. What do you think is an appropriate response when a patient asks their physical therapist what kind of graft they should recommend?
I actually love it. I tell my patients to do that because I told you patients come to me and they're like, I want an LAT. I want a quad. Patients come to me all the time, a quad tendon and an LAT, and that's what they want. And they come to me because they hear about that. And that's not my favorite graft choice, but I will talk to them and I'll say, go talk to your physical therapist and they'll tell you about the quad tendon and talk to you about the rehab because you have to really work very, very hard if you really want the quad tendon. And then it's a soft tissue graft healing and so they almost all come back and they'll say, I'll take the patellar tendon after they've done that. So I actually encourage them to go talk to the PT who will be rehabbing them.
Well,
Yeah, I would agree. I think it's the physical therapist because you get to see so many different surgical techniques and varieties of grafts. You probably have a lot better understanding than we do as surgeons because we have our own biases wherever we trained and what we've done in our practice. And we probably, I don't do many quad tendons. I've seen some quad tendons. They were done other places. I've done a few quad tendons for revisions. But you doing quad ACL recovery probably have a better idea than I do about their outcome and how they recover and how their quad comes back. And most of our data is from anecdotal stuff from our experience, or occasionally from studies like Robin showed. I think the therapist is a great resource for that. I think the other part of that is, like I said, I think the therapist communicating with the surgeon is great because I'd like to know if you, Kevin, find that somebody Brown is doing a quad tendon, patella tendon, hamstring, whatever, and they're getting great results, and you're worried about my knee extension, I want to hear about it. Whereas I think nobody wants to hurt anybody's feelings, but I think we all need feedback on our procedures and outcomes.
no, I agree. Thanks so much, both of you. We're going to move on to the rehab now. And again, keep the questions coming. Put them in the Q&A. We'll try to address them at the end. We've got about 45 more minutes on this particular webinar. So let's talk rehab. And I do want to be graft specific and build on what Dr. West and what Dr. Cain was mentioning. I'm in Birmingham, Alabama. Work closely with the Andrews group as well. This is our clinic here, just a little picture. I'm not a huge proponent of accelerated rehab, so I want to make that perfectly clear on the front end. I'm not that I'm opposed to accelerated rehab, whatever that means, but in the true sense of the word. You heard some great talks on where to put the ACL. This is obviously a cadaver and showing how far posterior the ACL is just naturally in that intercondylar notch. Also, an anterior view is very nice because it shows that semicircular orientation and similar to a very large footprint on the femoral side like Dr. Cain was mentioning. And also the ligament is almost like a twisted type of structure that Dr. Warren some years ago looked at reproducing in a cadaver. ACL injuries are common. A lot of times it's jump landing like you see here in a volleyball player that lands and a big valgus overload, a valgus collapse, if you will, but look at where her trunk was. Her trunk was way laterally displaced when she landed on that medial side of her foot. So that's something that we have to address in our rehabilitation, proper landing. It was mentioned earlier. Dr. Cain showed this video before where a person just making a deceleration and cut. And what I think is interesting, we talk about these injuries and we talk about turf versus grass. Maybe we can discuss this later. The majority of ACL injuries in the NFL right now have been on grass, only a few on turf. And some might think, well, there's not a lot of turf fields, but there still is a fair amount. This is an Auburn gymnast that plants a landing and unfortunately hyperextends both knees and dislocates both knees. One of the knees had a tibial plateau fracture as well. So again, a very severe injury in this elite athlete, if you will. So for me, I tend to see a lot of ACLs, thankfully, because I enjoy treating them. I'm in my fourth decade of, well, going into actually more than that, but 4 decades of practice so far. And I see about 400 ACLs a year. I see a lot of females, unfortunately, as Dr. West mentioned, especially a high school soccer player. So all these girls, five out of the six are soccer players with one lacrosse player on the end. And this is what it looks like coming in, right? First day of rehab, parents bringing her in. She's pale, she's scared. Moving pretty good though. One crutch and not too scared. And obviously this progression in this lacrosse player. Gradually working on motion. It's difficult in the beginning. Those first couple days are tough. Obviously, she's probably about a week there, and now we see her a little bit later on in her recovery. But it's a progression, and she was able to come back and play, win a state championship, was all state, and went on now as playing in college. And that's what we strive for, is to return you back to that pre-injury level. As I mentioned before, females, girls, soccer players are the most susceptible at the high school level to have an ACL injury, followed by boys football, girls basketball, girls gymnastics, boys lacrosse, then girls lacrosse. So out of the top 6 sports, 4 are female sports. We often think of ACL injuries as running, cutting, and jump landing. Well, in soccer, it's a little bit different. Numerous investigators have looked at this as far as looking at motion analysis and determining the number one reason in soccer for tearing your ACL is defending, which many times is unanticipated movements, which I'd like to talk about a little bit later on if we have a chance to talk about return to play testing. I'm very biased now as far as how I think the running, cutting, and also the jump testing should be done. It shouldn't be done with anticipated movements, but rather unanticipated, where we, the clinician, tell the person in which direction they're going to cut as they come toward you, so they have to react. Same thing with jump landing. This is going to be a high school soccer player in blue, going for the ball, and she's going to get bumped as she overstrides and tears her ACL. That little brush was just enough to cause her knee to twist and go into adduction. Tears her ACL, has an ACL reconstruction with a hamstring graft, and unfortunately fails during rehab. Has a revision, sees me, and we get her back. My team and I get her back for her senior year at university, and again, a success story. So we like that a lot. And we certainly know that there are a fairly high, much too high re-injury rate in these ACL individuals that we desperately want to reduce. Here's one of Dr. Cain's patients, a world champion water skier, jumping. In this particular jump, in the middle picture, she jumped 166 feet. She's hitting the ramp at about 45, 50 miles an hour, and sometimes even faster. But watch when she lands. That was the concern for me. There's nothing up to this point, but when she lands, she's going to go into a hyperflex position. She sits back on the skis, which generates a tremendous amount of quad. Sometimes we see people that tear both ACLs at the same time, and that creates a very logistic, difficult situation for the physician, patient, and the rehabilitation person. So what defines a successful outcome? Dr. Cain and Dr. West mentioned this before. Well, I showed you that lacrosse player. I think that's a success, but we only have her year and a half out. This girl is 3 years out, still doing well with her knee, playing recreational soccer. This guy's in the NBA, another one of Dr. Cain's patients. He's 3 years out, not having any knee problems. And then there's this 72-year-old hamstring graft who's now into his 3rd year of skiing. So they're all happy. So what's, in my mind, defines a successful outcome? Patient satisfaction. They're happy with their knee. Their knee is not sore. They're able to return back to their desired activity level in sport at the same level, or maybe even better in some cases. Asymptomatic knee function. What does that mean? No knee pain, no swelling, and they have a knee that's going to last. So it's asymptomatic knee, able to perform activities, at pre-injury level or above pre-injury level. Successful outcome today, like this elite soccer player who wound up playing in the Olympics at a very short time frame after injury, but also played professionally and also coach. And some 30 years later, I'm still in contact with her she played in the Olympics in Atlanta in 96, and 30 years later, she says her knee is still asymptomatic, even though it was a very fast return. So my experience with ACLs is pretty robust. I've been fortunate. When I first started, worked in Chicago, I worked with an Andrews physician who trained with Dr. Andrews at the Houston Clinic, and all I saw was extra-articulars. People were put in casts, lengthy immobilization, difficult to get motion back sometimes, and no intra-articular procedures. My second experience was with a physician in a different practice who thought tighter ACLs were the best and overly constrained the knee. We often had problems with getting extension. In that same group, a younger physician joined who were all doing allografts. There was an era in the times where physicians advocated just allografts, primary surgeries, even in young people, and it led to some severe complications. My present experience is a high number of patellar tendon grafts with some quad tendon and then minimal hamstring. So that's really dropping off. So when we think about how rehab has changed through the years, back in the mid 80s and late 80s, you were casted after an ACL at 30 degrees. There was a time when we used CPM, and there was also a time when very large incisions were made. Now the incisions are smaller. Care is taken as far as harvesting the graft. And I think overall the rehab is much better generally. So quad tendon to your left, patellar tendon in the center, patellar tendon with an LET on your right. Sometimes we have these complex meniscal tears. This is one of Dr. Cain's patients who the individual had a root tear, which we'll talk about, root tear of the meniscus, which really creates havoc. Dislocated knees are tough, and obviously beyond the scope of this presentation because of time, but watch this NBA player when he lands. And again, this is just a layup. There's an NBA fantastic player, and he lands on that medial side of his foot, and it completely collapses, and he dislocates medially. Big injury. This one on the left is a dislocated knee from a hyperextension injury, which actually compromised his popliteal artery as well, and was able to come back and is back at the college level playing. Here's a young man here, another dislocated knee from hyperextension, popliteal artery rupture as well, and both had to undergo vascular surgery. So we talked about this asymptomatic knee long term. So what are the key factors? Well, preoperative rehab, preparing the knee, successful surgery, and that first week is really imperative after the surgery. It really sets the tone for the rest of the time. And it also is important to fulfill certain criteria to progress from one phase to the other. So it's not strictly time-based, but it's how the patient presents with their range of motion, their quad strength. And also we don't want to rush the process, but we do want to have them move through in a timely fashion. I firmly believe that a neuromuscular program is an essential part of the rehabilitation that helps the patient improve their confidence and reduces their re-injury rate. So when individuals say they're not ready or they have kinesiophobia or they lack confidence, I really believe the program was deficient in the neuromuscular, neurocognitive aspect. By doing different drills, that enhances their confidence. So again, I believe in an equation for these patients, appropriate surgery, because it's not one surgery for all patients, well-structured rehab. You need a patient who's motivated, engaged, and compliant. They have to buy in. And the role of the therapist, athletic trainer, is to make them motivated, engaged, and compliance. Also, the return to sport is when they're ready. It's not based on time. And that, I believe, will equal a successful outcome. It's decision making. It's a team approach. It's gradually loading the joint and not increasing the physiologic abilities of that joint. It's also what we see when we evaluate someone, their range of motion, their strength, their swelling, but it's also what we don't see. What's going on in their head? Are they fearful? Are they apprehensive? Do they just feel like it's not quite right? Terry Shimoleski, who was one of my fellows some years ago, Terry's done some great work in this particular area with kinesiophobia, and she's published 3 really critical articles for us in the rehabilitation literature stating that there's a high incidence of these individuals that are concerned about their knee and just fearful of getting hurt again. So again, I think a neuromuscular program is essential. You have to build a foundation. The foundation is critical, and that's what we're going to spend a few minutes on. The phases, and then we'll get into neurocognitive and some things on exercise. So I think there's really 10 key components, if you will. The first one is preparing the patient for the surgery, both physically but also mentally. Pre-op rehab, critical. Get swelling down, get their motion going, and engage their quadriceps. Post-op, full knee extension. So comparable to the other knee, but some degree of hyperextension that we gradually build on. Gradually mentioning reducing swelling, because swelling and pain can have some inhibitory factors on your quads. Gradually restoring flexion, and with patellar tendon grafts and quad tendons, restoring patellar mobility. ACL injuries are not isolated. Even if they were lucky enough not to sustain a meniscus injury, they will all have a bone bruise, which can lead to radiographic changes, and they also have some central nervous system adaptation. We have learned that a large percentage of these people, and in my mind, I think 100%, have neuroplasticity. Neuroplasticity is just a change in the way you respond to a particular situation. Most of these are not deleterious, but there are people who have neuroplastic changes that are not preferred. Quadriceps avoidance gait is one of those. We also know that kinesiophobia and all these things are very important to override. We stabilize the knee from above and below. So hip control and core, foot and ankle. Hamstrings are certainly very important, but hip, foot, and ankle are critical. As I mentioned before, cardinal things preoperatively, swelling down, get their extension, and get an adequate amount of flexion. Also, quadricep activation. If you can't activate the quads prior to surgery, that'll create hardship as far as getting those quads going again post-operatively. Also, pre-op is great for the patient to learn about the exercises, what's going to happen in surgery, and ask those difficult questions that many times they're afraid to ask the physician. Control activity level as well. The first week, as I mentioned, is critical as well. That first day or 2, full passive knee extension, icing, a program that is routinely during the day as much as possible, patellar mobility, gradually gaining flexion, and quad turn on. So we use muscle stim on the majority of those people, and in hopes of getting muscle re-education and so forth. As far as getting extension on the knee, we like supine, overpressure. My preference is not doing any prone hangs, because it's really hard to hold or stabilize the hip and the pelvis. We provide low load, long duration type stretching, and it's important to educate the patient that they know that this is a critical component. Even though it hurts, even though it's uncomfortable, even though nobody wants to do it, getting your knee straight early on in the rehab and maintaining that is very, very important. So we use these apparatuses. This is called the extensionator from ERMI. We do know as you go into hyperextension, there is an increased strain on your ACL. So I think we need to be aware of that. For me, if the person has more than 10 degrees of hyperextension on their contralateral side, we'll go to about 5 to 7 degrees. And then we'll gradually gain the rest of that over the ensuing weeks. Past 145 degrees, there is strain on the ACL as well. We talked about hyperextension a little bit, and there have been studies, Dr. Shelbourne has documented, even a loss of 3 to 5 degrees will compromise the knee long term. This is called a heel pop. So we put a towel underneath the person's knee, we've got muscle stim on, so he activates it with a trigger switch, does a quad set, and the goal is to pick that heel off the table. So we know that he has good extension, good terminal knee extension, but he also can get into hyperextension. That ensures that he has good capsular play, but also good quad activation. This is why full extension is imperative. These are all knees that have scar tissue in the front of the knee. The one in the upper right is what we call a cyclops lesion. This is horrible because it's going to block their extension. It's going to cause pain, and probably in an athlete needs a second surgery at some point to go in and remove that scar tissue. Sometimes it looks like a cyclops lesion, and sometimes it just looks like diffuse scar tissue like you see in the lower right.
Ready? Yep.
Even in this patient who, another Dr. Cain patient with patellar tendon graft with an LCL, so not a LET, this is a person who tore their LCL posterior lateral corner. I'm ranging him, I'm going through an arc of motion as you see here, but I'm also have my hand on his tibia, and I'm actually displacing him or pulling a little bit anteriorly to take pressure off that posterior lateral corner. We do that a lot with PCLs. We do that a lot with posterior lateral corner. I mentioned muscle stim. We use muscle stim to override inhibition. So it's muscle activation, recruitment levels, and more motor units. By using muscle stim, we can actually recruit more muscle fibers than we can without. And it's predominantly used to try to get the person to gain volitional control. Going into that second week now, the game has changed. We were low level with our exercises, quad sets, straight leg raises, 90 to 40 open kinetic chain knee extension. And now we go for the quads. 2 weeks post-op, we start using still muscle stim, but we also use BFR, blood flow restriction.
Okay.
We like that for muscle hypertrophy, but
Was it
early
for-
on, it's really to prevent muscle atrophy. So here we're using a system that has a Doppler. So we generally inflate anywhere between 50 and 60% of complete occlusion. Rehab has changed dramatically in the last 5 years. And what I mean by that is this whole aspect of central nervous system plasticity. In years past, we thought when you tore your ACL, you had decreased proprioception because of a localized effect. And what we found was if you look at the opposite extremity, that also had decreased proprioception. And also the opposite extremity, the contralateral side, also had a deficiency in strength over time. So what we found was it wasn't so much as a localized effect, it certainly exists, but what happens is the information sent through the central nervous system to your brain, where you interpreted that information and where you responded to it, was in a different center from people who did not exhibit adverse neuroplasticity. So this is some wonderful work done by Dustin Grooms out of Ohio University and his team through the years, where they put people in an MRI device who had an ACL, and they just had them do a terminal knee extension. And what they found was that in people who had neuroplastic changes, maybe quad inhibition, they used different areas of their brain. Instead of a group of people who did not have neuroplasticity, they generally used one particular area of the brain. So this is a scatter plot that he put together. Bring it back a second so you can illustrate a little better. The ones in blue, and this is multiple subjects. The ones in blue are the ones who do not have adverse neuroplastic changes. The ones in red are the regions are the people who cannot or have negative neuroplastic changes. And all it was these people doing about a 30-degree knee extension type movement. Sorry about that. There's different areas of the brain that are responsible for different activities. We like to refer to it as open skills and closed skills. Open skills are more reactive, closed skills are more predictable. And that's my point about doing functional testing that's not anticipated, or the person is in charge of the task. stand on one foot and jump out and land on that foot. Instead, stand on one foot and I say jump and I tell you which foot to land on. Also, there's certain areas of the brain like the cerebellum that's very involved for coordination, highly skilled motor activities. We know our occipital lobe is very important with visual tracking. Some of the drills I'll show you in a second. And it appears that the occipital lobe and the visual aspect to this can be instrumental in decreasing that neuroplastic type of change. So it's been shown with concussions, it's been shown with ACL injuries and others, even upper extremity, that we want to integrate in this visual aspect for cognitive neuromuscular training. So this is an avatar system where he's basically tracking himself and he has to decelerate, hit targets. Here's an example of an NFL football player and a speed ladder. I'm moving the speed ladder as he's moving. I have him catch a ball. I throw it to him. So he's got to do some tracking. He has to do some throwing back at the same time while he does a coordinated movement. Very, very difficult to do. High level activities. These are called blaze pods. They light up. So he has to locate the target light, catch a ball, and not be distracted by the other colors. These blaze pods are 4 feet apart. Soccer player, 4 blaze pods. So we roll a ball to her or pass a ball to her. She's got to locate the target color. At the same time, protect her knee, which is her right knee, revision ACL, college soccer player. So it teaches her dynamic stabilization, movement skills. Anything that provides a stimulus or a challenge that's mental, visual, auditory, verbal, or kinesthetic that occupies an athlete's attention while they're completing a movement or skill is called neurocognitive training. So we like that a lot. Here's another example where a person is going to do a speed ladder. I've given him 2 drills. I'm going to say reverse when he has to go backwards. I'll give him another drill where I say switch, but I'll throw a ball to him so he can't break stride. He's got to keep his stride going, but what you don't hear is he's counting backwards from 100 by 7. Very, very difficult to do. And he's doing a great job with that. We do perturbation training where they're on a rocker board. The rocker board is tapped to be thrown off balance. The knee is slightly flexed on this person, so there's a co-contraction. A ball is going to him, he's got to catch it. We'll tap the platform because what we're looking for are these quick reaction, type 2 muscle fibers, fast twitch in particular, the 2B. Those are the ones you want to rapidly fire to stabilize your knee. You're not going to get that doing isotonic strengthening. You need isotonic strengthening. You need to do squats, but you need to do quick movements to make those adjustments. And I think a lot of times we miss that in the rehabilitation. Perturbation training has been shown to be successful and improve outcomes. There's a young lady, a high school basketball player, patellar tendon graft on the right, dribbling a ball. We've got her on a rocker board that we're tapping, and we throw these hexo sticks to her where the limbs are different colors, and we call the colors out, and she has to catch it. This is an example of a hop test that we do today. I say ready hop, and I call the foot that he has to land on. Yeah. Same young lady doing blaze pods, dribbling a ball. So again, she's got to focus on the skill, but she also has to focus on the tracking, the dribbling, a lot going on. So we're almost creating a chaotic environment, and that chaos stimulates different centers of the brain, which overrides, again, maybe that inhibition area, maybe frontal lobe in particular. 2 soccer players, the one on the left, college, the one on the right is professional, also plays for US 18 age group. And they're both on rocker boards. One is getting a band where it pulls into valgus and has to control it. So again, we're training the brain, which is imperative to balance, coordination, and skill. There's even these caps that are available, super expensive, that can, in real time with running and cutting, give you data on what areas of the brain are active and what are dormant. Do a lot of jump landing. It was mentioned, Dr. West talked about jump landing and faulty mechanics as a risk factor. So here she's got to jump, locate the light. So she jumps in the direction of the target light. Want to prevent that. Want to prevent that valgus collapse like you see in this pro basketball player. She gets bumped, which throws her balance off and was enough to cause an injury. So what I'm going to do with this young gymnast, I have her doing jump landing, but I actually push her in the air. So I create a postural disturbance in the air that she has to stabilize. Super high level, but again, she tolerates it well. Those are resistance bands that create resistance to the limb. Multiple neuromuscular tasks at the same time. A stagger step while he's locating a target light on the wall. Really tough to do. And a lot of these exercises, if you're interested, are on my Instagram. Not everyone does these proficiently. Here's a young lady just doing a lateral slide with resistance band. And what I'm going to do is I'm going to throw a ball to her. And every time I throw a ball to her, she stops. She can't dual task. She's not quite ready to do that. We've published several articles on this. This is one that we did a two-part series with a few of my fellows, Morgan Ivey, Zach Thomas, and Louis Lipowitz, published in the International Journal of Sports PT with ACL patients, where we basically documented in different phases, what are we trying to accomplish? How can we turn it into a neurocognitive demanding exercise? And what would be some examples? So we're just trying to give you examples of what to do. The phase two, or part two of the article, was the more advanced phase of the rehab. And this kind of gives you an idea. So we use different variables such as speed, resistance, what kind of dual tasking, and we gave you those components. So let's mention a few more things. We're going to wrap this up in about 5 minutes and open up the questions. I want to just speak for a second as far as different grafts and different surgeries and what you might want to focus on. So we had great talks on what grafts are available, and I think each one of these represents a little different challenge. I think graft-specific rehab is very, very important. Several studies have shown, I think Dr. West showed one where as different age groups and different recreation, the type of graft that you choose is different. A 45-year-old recreational non-pivot athlete is going to get a different graft than probably a 20-year-old elite, but it does depend on what those people are doing. Graft strength has been well documented. So let's talk quad tendon because that seems to be increasing in popularity. Why? I'm not quite sure, to be honest with you. Maybe to decrease anterior knee pain. So often quad inhibition is present. We've seen a bigger problem activating quads after a quad tendon. Doesn't mean forever. It just means in certain people, it may persist a little longer. The other is gaining flexion past 110, 115. They do well to 90, no problem, but getting beyond there can be painful. So it's a little slower to obtain hyperflexion, which my goal long term is to get your heel to your glute. I think we do have less anterior knee pain. I think overall later the time frames are very similar. I also think this is a patient that requires a little bit more soft tissue work in the suprapatellar area. So we do, once the incision closes, the incision is well healed, we do instrumented assisted soft tissue work in that area. So maybe a little bit more soft tissue. It's a soft tissue graft, so it's soft tissue to bone, healing on at least one side. So we have to have some precautions. But it continues to be a popular graft. What about hamstrings? Well, that's falling a little bit out of popularity with the replacement of quads, probably plateauing and decreasing, definitely less anterior knee pain, easier to get their quads going, easy to get passive range of motion. So what's the problem? Well, it's a little bit slower rehab as far as getting back to sports because it's soft tissue bone healing again. It's easy to rehab, less pain. I mean, if in a 45, 50-year-old, maybe 6-year-old active skier, I think hamstring is the way to go personally. It may be a potential problem as far as hamstring weakness. Dr. West mentioned that, especially for females that are so important to have their hamstrings. And again, potentially higher failure rates. The international investigators have reported that, but certainly with LETs that can be decreased. Last thing is patellar tendon grafts, the gold standard. Faster rehab potential because it's bone, tendon, bone to bone healing. Anterior knee pain is possible, even though we see a pretty low incidence. If anything, we see more patellar tendon soreness and less patellofemoral. It's pretty easy to get your passive range. Tough to kneel on, though. That's the problem. And long-term results are good. Contralateral grafts. We published a couple papers on this. Dr. Clancy, when he was here, he actually did primary contralateral grafts where you tore your left ACL. In this case, they took the patellar tendon from the right side. And the first couple of weeks, a little bit tough, but these patients actually went through rehab pretty quick. Rehab strength on the graft side returns at around 80% at 6 months and completely at about 9 months. Extra-articular, you heard a great presentation on that. Motion sometimes for me can be difficult into flexion. I have not experienced problems in extension, and so that's interesting. More people I talk to, Dr. Williams, Dr. West, others that do a fair amount of LETs have said it's a bigger problem in extension. The ones I've seen here, it's been a flexion problem. They do have some lateral knee pain. IT band, not really. Quad activation can be a little bit difficult, but I think it's more based on your ACL graft. Stability is definitely enhanced, and long-term success, it seems to improve, as you heard from the Stability 1 study. This is a guy who's just about 2 years out now. College soccer player, patellar tendon graft, LET, and I still can't get his heel to his glute. Really tight. Really had to torture him to get him to that point. But is it the LET? Is it the technique? Is it the overly tension placement of it? Was a Lemire procedure. The other is many times we see rotational tibial restrictions with an LET. So that's something to consider as well. Tibial slope correction. Great presentation. I don't have much to say other than what Dr. West said. Last thing to mention as I run out of time, these meniscal tears. Really, really important to communicate with your physician so you're all on the same page as far as what to do from a rehabilitation standpoint with different types of meniscal tears. A longitudinal tear that's repaired, no problem. Weight bear, full extension, don't alter your rehab very much. A complex tear, like what you see here, a radial tear, that's repaired. You can't weight bear that, or at least not in an expedient fashion. And then you have these root tears, 1 through 5, that involves the horn of the menisci. These are repaired because you're trying to prevent it from being an extruded meniscus. Tough rehab on this. This is much slower. And as Dr. Cain mentioned, the menisci are critical to long-term knee function, but many times when I see some of these surgeries, it is tough to get motion back. They do have some joint line tenderness and so forth. This is one of our patients here that experienced a severe root tear with ACL, hyperflexion injury with rotation. Ramp tears. These are the ones that you see near the meniscus capsular insertion or attachment, if you will, back here. And these are repaired, again, to help stabilize the menisci. Dr. Fu and Dr. Thompson has taught us that these menisci move, the medial 5 millimeters, the lateral 11 to 12 millimeters. We know with passive range of motion, it's basically the condyles that push the menisci anteriorly and posteriorly. And in the open chain, if you will, and let me rephrase that. I apologize. I misspoke a little bit. Passive meniscus displacement with weight bearing is the condyles pushing it. So when you squat, you roll up on the menisci and it slides. In the open kinetic chain, your hamstrings pull it back and your quads through the quadricep expansion into the capsule pulls it forward. So what do we do from a rehab standpoint? Longitudinal tears, as I mentioned, heal quickly for the most part. Partial weight bearing on crutches, 3 to 4 weeks. Full weight bearing shortly thereafter. Return to sports. If it was isolated, 4 months to 5 months. Longitudinal red on white, a little bit slower. Root tears, as you see here, much slower to go back. They're non-weight bearing. You have these in your handouts as far as non-weight bearing for 6 weeks with a root tear that's repaired. No active knee flexion, particularly with resistance past 90 for 4 to 6 weeks. I don't really do a lot of hamstring work for 2 months with those individuals, and I tell them they can't do any deep squatting past 60, 70 degrees for 3 months. As far as return to sport on an isolated root tear, that's 5 to 6 months. So you need to be very protective. Last couple concepts. Bone bruises. Bone bruises happen in 100% of ACLs. Dr. Potter showed us that. They also have a 50 times more likely aspect on the lateral femoral condyle to have radiographic changes. The size of the bone bruise in her study dictated degenerative changes 1 to 3 years. So what does that mean for us in rehab? Faster is not better. Smarter is better. Be smart with their joint. That's what's going to get them in trouble long term. So we might put them in the pool, water up to their waist at 50% body weight to satisfy their running or their activity. Or we'll put them in an Ultra G where we unload them. We put them in, fill that up with air, and maybe have them moving at 60% body weight or 50% body weight and teach them to put equal weight on both sides. I think with that, because of time, I'm going to stop there. You have some additional information in your handouts. So I want to have the opportunity to maybe have Dr. West comment also on the rehab and also bring in any questions in this last 5-10 minutes. One thing I didn't get a chance to mention, Dr. West, and I had a slide on it, was this whole concept of 9 months or greater to go back. You know, my hang up with that, quite honestly, and I agree with it wholeheartedly, but my hang up with that is by 4 months, most people run out of visits. And I don't think it's a time base. They got to be doing something in a progressive manner from 4 months to 9 months to make it worthwhile. If they stay on the same program or they burn out and don't do stuff, I think it's a disaster. And I think that data goes out the window. Your thoughts on that?
Yeah, I totally agree. I mean, most people have 20 sessions of PT, so they're out of those by 4 months. But I agree. You know, I think that sometimes some of the PTs I work with, and then they're all excellent, but they'll set certain parameters, right? You've got to be at 90% of your strength or 80% of your strength before you start running, or 90% of this before you're cleared. And so I have so many of these athletes who pass all aspects of their functional testing, but they're at 85% of their eccentric quad loading or whatever that test is. And they'll
Mhm.
come to me and say, I've passed everything and they're flying colors, everything across the board. They're psychologically ready. They're physically ready. They look great in my office, but now they're only at 85%. And so the PT says, I'm not going to clear you. And here they are. And I think that's actually the hardest part from my side because when I see those people and they're 10, 11 months out, or they're approaching, 12, 13 months and they still can't get beyond that. And when do you clear them?
Yeah, I mean, I think, you rely on a lot of things. One, your clinical exam, how their knee feels, how their knee is reacting, but also functional progression. So, if you're clearing them, the question is, at 9 months, what are you clearing them for? Is it practice situation or competition? Um, we wrote a paper on that some years ago with some people out of Europe that said, when you say return to play, as a clinician, it's actually a continuum. Performance training, practice, game.
Yeah.
And sometimes we miss that. I think coaches miss that too. They hear from a physician that says, well, they can go back, whether it's a baseball player with throwing, right away they think they can pitch in a game. It's like, well, no, we're 2 months
Right.
away,
There's a
right?
ramp up. I always tell them you've got to ramp this up. And is it a 6 week ramp up, 8 week ramp up? Like it's depending on their
Yeah.
sport and where they are.
Yep, exactly. And I think I'm going to bounce this off of you and hopefully get the support of people on this webinar is I think we as clinicians, whatever that means to you, PT, MD, ATC, when you have these kids, especially high school kids, and there's some way that they can do it and they run out of visits at 4 months, we say, you know what, we want to see you every 3 weeks. or we want to communicate somehow 3, 4 weeks, and we want to progress your program. It's your responsibility to do it. Now you can come in, you can self-pay, or we can do it a group, or you can do it with a strength coach or your trainer at school. But somehow that program has to become more and more challenging. And I would offer, and I'd be willing to bet a lot of money on it, that the more we do that with individuals, we would cut down on this re-injury rate as we return them back at 9 to 12 months instead of just relying on time-based.
I totally agree. I mean, I think that time based to me is not really, I don't, I tell them it's at 9 to 12 months just because that's what I think they're functionally ready, but I don't base it on time. I don't say, okay, you're 8.5 months. We have to wait a certain amount of time. If they're, 8 months out and they've passed everything and they look good, then we'll start ramping them up.
What
But
return to play testing do you do, Robin? What do your people
I
do?
rely on my PTs, so they're the ones who, but yeah, I mean, I think it's a combination of a lot of single leg stuff, reactionary stuff. I'm a big believer in everything that you were showing, all the reactionary, that, again, multitasking,
Hmm.
and then the
Yeah, it's kind of,
psychological readiness, I think, is a really big deal.
yeah, and I think it's, I hate to use the word silly. I just don't know what else to say because I'm obviously a little tired. But I think it's kind of short-sighted, maybe is a better word, for us to think that a person stands on one foot and jumps out or jumps repeatedly 6 meters and is comparable to the other side. They're ready to go back.
I agree.
And I've spoken to Dr. Noyes about it because obviously he came up with those hop tests and I respect him greatly. And I think they're fantastic as an entry level, but that's not what's happening out there. That's not how you get hurt. You don't get hurt knowing what you're going to do. You get hurt when things are happening that you get bumped or you have to react and,
All the testing you were doing, all the reactionary stuff.
right,
And I
exactly.
think implementing that early on as soon as you can, again, because that takes a long time to retrain.
Yep.
Yeah, it's amazing to me when we look at that quad function, even just getting that quad activated. And that's why
Yep.
I train my patients pre-op and then post-op. And then in the recovery room, they're activating and they're doing these leg raises. And I just tell them because there's this brain disconnect and you have to re-educate your brain. And so I think the earlier that you can start doing that, I think it's really important.
Yeah, and that's, my hang up too is, I've been guilty of this is post-op stim on. Can't contract, more stim. Take the stim off, can't contract. Put the stim back on, you can
Right.
contract. It's not a question of re-education. It's just something is going haywire. They have to
Yeah.
rewire their brain, so to speak. And
I
so
always
there's
have them look
tricks.
at it, and I don't know if you do, but I have them stand like, or I have them sit up and look at both legs, and I say, look at that patella, look how that engages, and look at the other side, and now do it. And all of a sudden, they can do it, and it's so interesting. They'll come in, they cannot activate their quad, they can't do a leg raise, and I have them sit up a little bit, look at the other side, do that, again, get that little kind of heel pop, really try to work with them on that, and then all of a sudden they
Yep.
can do a leg raise, and they're like, I haven't been able to do it.
Yeah, because once you get behind, it's really hard to catch up.
Hard to catch up.
Hard to catch up. And they can be months and months behind. You go to test them and you're like, how did you ever get this far behind? I would offer that it started from the beginning and it just progressively never kicked in. And there's tricks. We didn't get a chance. I mean, I had a lot more on the talk, overestimated myself as far as talk speed. But there's a lot of tricks that we talk about at meetings where we use the lights as somebody's doing quad sets even and counting and virtual reality glasses and strobe glasses. There's a lot in the literature and there's more and more coming out. So questions are rolling in, but our time is getting short here. Let's just say a couple things and we'll wrap this up. We do reactionary testing, and those are a paper that we published International Journal of Sports PT about 2 years ago saying we need a change in the way we test. Standard tests, yeah, we do a hop test, we do a biodex. I tend to do torque to body weight ratios. That's my thing. Also hamstring quad ratio. We look at limb symmetry, but it's not my number one priority. It's torque to body weight, but that's me. And I also look at acceleration rates. Y balance is okay. It's just not dynamic enough. Um, and I don't know. I don't know what else to say. Robin, what on the testing? What else as far as closing thoughts?
No, I mean, it's obviously it's individualized for surgeons, and so you'll see some surgeons again using something, and that works for them. But I think that communication's key, and I think Lyle talked about that. And I give my phone number out to basically all my patients, and I tell them to pass it on to their PTs. And the PTs we work with are in a very broad area. A lot of people are traveling in for surgery, but I want to talk to the PTs. I want to know early on, so I would reach out and ask all of you to just, make sure that you're communicating with the orthopedic surgeon who's done the surgery because we want to know what's happening. And if
Yeah.
the surgeon doesn't want to know, then that's there's a problem. But we need to know, good or bad, what's going on.
Yeah, that team approach is critical. I mean, it just makes it work for everybody. And the patient's the one that wins the most, but also we win as clinicians. It's more
No, it makes us all
stimulating.
look at. I always say my part's a small little part. I'm going to lay the groundwork and do the surgery, and then you have then the year ahead of you to work and working really diligently with your PT. But it's a team approach, and the goal is the patient and getting the best outcome we can.
Yep, absolutely. Is there any time that you don't want full extension?
No, I'm like you. I really try to achieve even the hyperextenders. I'm like you. Like I'll try and achieve that early,
Hmm.
just that a couple degrees, and then start to let them work their way into it.
Yeah, as they
I
gain
like getting
control.
it.
Yeah.
People do
Yeah,
not like having that
I'm
difference.
the same. And I'm just seeing more and more patients struggling to get their extension, as
Yeah,
they come back for rechecks and stuff. And it drives me bonkers, but
yeah, me too.
because it's
It's crazy.
preventable. Lyle, are you still on? I know he had a previous commitment, but at any rate, I want
Yeah,
to thank
yeah, I'm here. I'm here, Kevin.
oh,
Yeah.
Lyle, closing thoughts. I'm sorry. Any closing thoughts as well?
No, I mean, I think great discussion. I think with ACLs, Don Shelburne showed that 3 degrees of extension loss compared to your non-injured leg is worse than being ACL deficient the rest of your life. So extension is definitely important. I mean, that's we focus on extension. We fix our grafts on ACLs, and I think that's, from a care standpoint, that's our first goal. So I think it's really important. As far as grafts are concerned, I think all the grafts have great options. They all have their own upsides and downsides. I think it's really about how you put it in, where you put it, how your rehab starts, um, and deciding early on that you're going to work it aggressively. I don't like anybody coming back at 2 weeks without a full extension. I think that's probably the worst thing that could happen with an ACL.
Yeah.
Yep. And Lyle, I bug you all the time with texts and calls, just like Dr. West was saying, that communication. So thanks for answering. Same thing with you, Dr. West. I've seen some of your patients who are always quick on the draw. It's very impressive, both of you, the way you practice.
Thank you.
Yep.
Thanks for all your help, Kevin.
Yeah,
Yeah,
we're
absolutely.
blessed to work with you. So
It's our privilege to work with you all. I want to thank everyone who joined us. Don't forget, you will have PDFs. Sean has put them in. You also get an email with these PDFs of the talks. And also, I think you can view this again. I think there's a link that you'll be getting that you can view again. So thanks so much for joining us. And special thanks to Dr. West, Dr. Kane for their time. I know they're terribly busy, but it was great. Great learning opportunity. Thanks
thank
for
you so
sharing.
much. Thanks for having me.
Yep, absolutely. See you, everybody. See you on the next one.